We are live.
Good morning. It's a very nice Sunday morning, and we bring to you the third edition of GuruSangam, which is the AIOS presidential initiative to educate, elevate, and excel. That's the motto. It's a exercise to encourage teachers and set a standard of teaching in India, and that's the effort that we are at. So this is the third episode, and today we have 5 lectures. Dr. Harbans Lal is the president of AIOS, and he conceptualized this program. We have Dr. Tinku Bali, who is the member of Academic and Research Committee of AIOS and consultant at Sir Gangaram Hospital, who's going to moderate the session. Tinku will take over.
Thank you, sir. Thank you so much. So we welcome all the speakers to this new edition of Guru Sangam, and also my very warm welcome to all the audience who has logged in. I would request all the people who have logged in to make this as interactive as possible. So please put in your questions, doubts, perspectives, any comments in the chat box, and we'll be taking them at the end of the talk. So with that, we start with the first speaker. So our first speaker is Dr. Virendra Pal, who's a professor in the Department of Ophthalmology at the Varun Arjun Medical College, Shahjahanpur, UP. Postgraduate from the King George Medical College, Lucknow. He did a fellowship in Cataract, SICS, and FACO from the Arvind Eye Hospital, Tamil Nadu. After that, he joined the PMS, and subsequently he joined the Sitapur Eye Hospital, where he worked as a professor and deputy director. He very actively organized numerous conferences and also taught a number of students. He's published and presented extensively and been organizing a lot of free community camps. Apart from being a good surgeon, he's also an excellent Hindi poet and has also published Hindi poetry books. So over to Dr. Virendra. Dr. Pal is also my personal friend. He's been my, my colleague in post-graduation. So I look forward to hearing him. Dr. Virendra, are you logged in? Yeah. So I welcome you all. I welcome you, Dr. Pal. And Dr. Pal would be presenting on small incision cataract surgery, and I'm sure he'll give us a very good perspective on the intricacies of this surgery. Dr. Pal.
Thank you, Dr. Tinku, for nice introduction. And thank you, all of you and all in the Ophthalmic Society and organizing committee of Guru Sangam. And really, I am thankful to give me an opportunity to share my knowledge on this prestigious platform. So now I think I move on my slides. So just I am sharing my slide. Yes, now it's okay. Yes, I am audible or not?
You are audible.
Hello. Yes, yes. My topic is small incision cataract surgery.
You can make it full screen, sir.
Yes, sir.
Go to show. That's it. Yeah, perfect.
So my topic is small incision cataract surgery. It's not. Yes. Okay, small incision cataract surgery is an excellent manual and low-cost technique for individual as well as for mass cataract surgery. So what is the gold standard cataract surgery? As we all know that phacoemulsification with foldable lens implantation is gold standard cataract surgery in modern era because it has small self-sealing incision, sutureless, bloodless, nearly not inducing post-operative astigmatism. Even it reduces the pre-existing refractive errors and very early rehabilitation. But unfortunately, it's expensive, machine-based, and required highly experienced surgeon and having deadly complication like endothelial
Sorry
cancer.
to interrupt. Can you go into slideshow mode because your slides are not moving at this point?
Yes, sir, I am moving, but yes, now it's moving.
You have to go to slideshow, which is at the bottom of the screen, that blue bar, the third icon from the left.
Doctor, can you just stop and reshare?
It's moving manually.
Yeah,
Just stop and reshare, sir. I believe. Can you just stop and reshare?
Stop and reshare. Okay.
When the pop-up comes, just press the blue button. Yeah.
Yeah.
Just make it full screen, sir.
So now it's okay.
Yeah, but make it full screen. That's it.
Full screen. Okay.
स्लाइड शो जो है उसको एक बार
Yes.
प्रेस कीजिए.
So, so now it's moving. or
स्लाइड
not?
शो में भी नहीं गया है.
Okay. So now come to the SICS. Now it's
नहीं गया
visible
है,
or not?
Sir,
Yes, sir.
Dr. Pal, can I request you one thing?
Yes, sir.
Just stop for a minute. I'll guide you step by step. Just stop first.
So, sir, stop here or
Stop share, sir.
okay, okay.
Just click on the green button, the share screen button once. When the pop-up comes, don't select anything. Just press the blue button. Just press the or select the option screen.
Now share.
And now, can you please make it full screen?
Yes, sir. Yes.
स्लाइड शो को प्रेस करना है.
Sir, can I present on
Next
mobile?
एक बार इस पे ट्राई कर लेते हैं. सर 100% जहाँ लिखा हुआ है नीचे उस पे उसके साथ एक
Yes, sir.
आइकन बना हुआ है.
Yes, sir. Now,
Slide
now
show
I am
उस पे क्लिक
showing on full screen. SICS slide. I am full screen on.
हाँ, ये इस पे नहीं दिख रहा है सर. एक्चुअली इस पे बस वही रिव्यू मोड पे दिख रहा है. सो 100% जो लिखा हुआ ना उसके लेफ्ट वाली जो बटन है उसको प्रेस करना है. नीचे बॉटम लास्ट.
सर बॉटम में स्लाइड के नीचे एकदम सर.
No button is visible on bottom, but all are visible on the top.
हाँ, 100% करके है ना सर नीचे. सबसे नीचे वाला बॉटम राइट साइड आपके स्क्रीन.
or you can go in the top menu slideshow.
Slideshow menu. So you share, pause, summary, AI, note, remote control, app, more.
हाँ ना, पावर पॉइंट का फंक्शन है सर. ये पावर पॉइंट में आपको शेयर करना पड़ेगा.
Sir, again I stop and share.
या और
Sir,
सुनील,
this time when you share, when the pop-up comes, don't select anything. When the pop-up comes, just select the option screen and then do the share. Don't select anything, please. When the pop-up comes, just select.
So now 100%. Yes.
ये जो नीचे 100% है उसके
हाँ, yes,
लेफ्ट
sir,
बटन
100%.
स्लाइड शो पे दबाना है.
So now it's visible or not?
जो बॉटम का आपका आइकन है सर उसको एक बार प्रेस कर दीजिए. 100% के साथ है नीचे जो टास्क बार है उसमें नीचे एक छोटा सा आइकन बना होगा 100% के साथ. या 100% लिखा होगा.
सर मैं मोबाइल पे करूँगा. आई थिंक इससे 100% आई है. प्रेस 100%.
हाँ, मोबाइल पे ट्राई कीजिए.
Did we go to the next talk?
Yeah, we could do that actually. Yeah. In the meanwhile, Sunil, you can get his presentation and we can advance it from here. We'll go to the next talk.
Okay, fine. So while Dr. Pal works out this connected with this issue, we'll go on to the next speaker, who's Dr. Preeti Srinivas Raghavan. She's currently the Regional Head of Medical Services, Gauchibauli, Hyderabad, and the Chairperson of the Education Committee of Clinical Board of Dr. Agarwal's Group of Hospital, a senior phaco-refractive surgeon with prime focus on premium cataract surgery and complicated cataracts, and also medical retina. Her academic achievements include securing the state rank in higher secondary schooling. She's been a gold medalist and has won numerous accolades. She did her MS ophthalmology from the Arvind Eye Hospital, Madurai. She's performed a lot of cataract surgeries, 25,000 cataract surgeries, and she's an expert at handling all the aspects of surgeries. She also does anterior segment surgeries and refractive surgeries. She's been publishing and presenting extensively. So over to Dr. Preeti, who will be presenting on cataract premium IOL surgeries. So look forward to your talk.
Yeah, a very good morning to the panel, and I thank AIOS GuruSangam for giving me an opportunity to have my presentation in this esteemed podium. And I thank Dr. Santosh Noor sir and Dr. Ash and the leaders in the AIOS. I'm going to share my screen now. Please let me know whether the screen is visible.
Yeah, you can make it slideshow now.
Yes.
Correct. Perfect.
So my topic for today is premium IOL surgeries. Thank you for a warm introduction, Dr. Tinku Bali ma'am, and let me go ahead. I have no financial interest in this presentation. And premium IOL surgeries, where do we stand? It's a goal-driven technology, and this is an era of refractive surgery. So we need to remove cataract through the smallest incision possible, followed by an ideal IOL implantation and achieve rapid visual rehabilitation for the best unaided visual acuity. That is the goal. So the evolution in the machine, which is phaco machine advances, the evolution in the material, the IOLs which we use, and evolution in the biometry has made this possible to have this, to be in this era of refractive cataract surgery. Going premium. So what do I mean by going premium? You need to handle the surgery, handling the surgery, and handling the patient. 4 P's of premium IOL surgeries, I would say, are preparation, which is the biometry and marking, precision, the surgical technique involved, patience, the chair time before and after the surgery, and pricing, where we need to know about all the intraocular lenses. And the thought of going advanced or premium started with Dr. Sir Harold Ridley inventing the intraocular lenses, following which the advances by Dr. Charles D. Kellman, who dared to take on the medical world by introducing the phacoemulsification. From there on, we have been having a great evolution of intraocular lenses, from the original Ridley posterior chamber lens to the modern capsular posterior chamber lenses and modern anti-capsular anti-chamber lenses. And today we see around 350 lenses available from the time we started in 1949. And with the evolution of biometry, the IOL master significantly changed the way biometry is performed, and it continues to do so with a lot of new formulas which come up, which help us to identify what is best for a patient with all our knowledge in place. So what is an ideal intraocular lens? An ideal intraocular lens would restore the patient's vision without undue complication or visual compromise and allow the patient to regain his or her ability to see at all distances. So going premium. So what do we mean by premium intraocular lenses? So they start with aspheric IOL, introduction of asphericity, enhanced monofocal. Then comes the multifocal, which are bifocal and trifocal. Then we have the panel of extended depth of focus IOL. Then are the accommodative IOLs. With all this, there is also a toric component. If the patient has astigmatism, that needs to be corrected to put the patient bang on 6 and 6 post-op. So premium IOL technology, let's see that first. See, IOL biomaterial, aspheric design, and special refractive property. All these leads on to the premium IOL technology. So biomaterial used for premium IOL should ensure excellent long-term UVL biocompatibility based on inflammatory foreign body reaction to the eye against the implant, and capsular biocompatibility determined by the relation of the IOL with residual lens, epithelial lens within the capsular bag. So different materials which we normally see are the hydrophobic acrylic, hydrophilic acrylic, silicon, PMMA material. Hydrophobic acrylic material presents highest level of adhesiveness. Anterior and posterior capsule fuse with the IOL and prevents its decentration or rotation, which is very important when we aim for an aspheric IOL in the bag and well centered. So the first premium will be aspheric IOL. So wherein we have the human eye, as we know, is an aspheric optic. Cornea has got a positive spherical aberration. The young crystalline lens has a negative spherical aberration. Aging crystalline lens increase positive spherical aberrations. And the conventional IOL increases spherical aberration of the eye, basically. How do we overcome this? And we put in an aspheric IOL. It attempts to improve the pseudophakic vision by controlling the spherical aberration. So the strategy number one will be, you put in a negative IOL with a negative aspherical aberration to balance a normally positive corneal spherical aberration, or lens with a minimum spherical aberration so that no additional spherical aberration is added to the corneal spherical aberrations. So benefits of the same are better contrast sensitivity, better mesopic vision, nighttime driving, and there are some examples. Challenges and limitation, you definitely need a perfect centration, decreased depth perception may be there, little more expensive than norm, so that it may not be applicable to the mass population, but definitely when a patient comes for you for a premium IOL surgery, you need to go for this. And then these are some examples of the trade examples of aspheric IOL, which is available in the market, just for us to have an understanding and not with any financial interest. We have platforms from Alcon, we have platform from the Bosch and Lomb, and we have platforms from the Johnson & Johnson companies. And the next will be a multifocal IOL or a toric or a trifocal IOL or a EDOF. All these they are single IOLs with 2 or more focal points, enabling the patient to see distance, intermediate and near, or have a continuous range of focus, rather than just having a distance and having a patient wear glasses for the intermediate and near. So these are the next premium brand which we are supposed to know. And the types are, you have refractive, we have been refractive, which have concentric rings of different powers, which enables the focus in different areas, and then diffractive or a combination of both, which has come into play now. So just a basic of what a refractive multifocal will be. It started with a 2-zone lens where you have the central near vision segment surrounded by a distant vision segment. The central section is 2 mm in diameter generally, since pupil constricts during near vision. And when the pupil dilates during distance viewing, peripheral distance segment is exposed. The disadvantage is in bright light, poorly tolerated by patient enjoying outdoor sports. And then you have the annulus design where the centralmost will have a distance surrounded by a near, and then again surrounded by a distance vision. So this is the basic by which a refractive model is made. Marked pupillary constriction allows distant vision, mild constriction allows distance and near, all 3 segments exposed when pupil is dilated. So excessive constriction during reading in bright light blocks the near ring, and it can prevent a clear vision. So these are little disadvantages, and then it evolved to having these multiple rings in place, and which will have a central distance or the central intermediate, and then you have a circle for the near, and then basically you have a circle again which comes in for the distant vision. So, and then came the diffractive multifocal IOLs. If you see, they have micro engineered with microscopic steps of specific phase delay, we say, usually half a wavelength. This is based on the Eugene Fresnel principle. Light entering these steps is directed, if you see the diagram, it is directed equally between the distance and near focal points for all pupillary diameters. So thus, diffractive IOLs are pupil independent. We need to understand the different model of IOLs to choose the best for our patients. That's why this explanation comes in. And then these are the multifocal IOLs with different ads. You have a low ad, you have an intermediate ad, and you have a higher ad. So as told in the previous diagram, this lens shows a step pattern from the periphery to the center. And there is a clear zone in between. A similar thing happens below as well. So these have different specific properties, and they have a specific optic and a haptic design as well, which will enable the patient see clearly at multiple distances. So the basic difference all of us have to know is refractive multifocals, which were initially present, and the diffractive multifocals, which later came up, and then a combination of diffractive and refractive, which is currently available to us. So when we see about the refractive multifocals, as said, they are very good for intermediate and distant vision, whereas diffractive multifocals have got excellent reading vision and very good distant vision. In the refractive multifocal, it may not be sufficient to see very small prints. This also has the diffractive multifocals also has a fair intermediate vision. And the refractive multifocal, patient who read for prolonged period of time or in poor lighting may experience a little fatigue. And in diffractive multifocals, because these are all bifocals, which we are currently discussing now, patient who do a lot of computer work may not accept. So the refractive ones are pupil dependent and the diffractive ones are less dependent. So that gives, so that made us think and evolve into having a These are the diffractive multifocal which are present, which is accuracy of IQ restore. Few properties we should know, and but the difficulty in a bifocal made us evolve more premium into a trifocal segment where you can do a Google map, see the steering wheel clearly, and still drive into the tunnel. So that brings us to the important part of intermediate vision, which is also very important days where we have computer use to a higher extent. So the trifocals provide better intermediate vision with fewer side effects by using a second order light diffraction and asymmetric light distribution. If you see this diagram, uh, it distributes 45% of incoming light to the distance, 20% to the intermediate, and around 30% to the near. So you have specific three focal points, and the dioptric power of the near focal point was twice the dioptric power of the intermediate focal point. This is on the simple, trying to simplify a complex physics so that all the ophthalmologists across, we are able to understand it, even if we know physics a little lesser. So this is how the trifocal works. Some of the trade examples are Acrosoft Panoptics, at least our trifocal, which is from another company by Zeiss, and then the Physiol Fine Vision trifocal as well. And then we have this something coming up, and all these have side effect because of the multiple rings. As I tell my patients, the multiple rings make the light fall at different places. So when the pupil dilates as they go in night, you will have a lot of glare and halo. So then we evolved more premium or to have a specific benefit into something with lesser number of rings, but still serving the purpose to some extent, to most of the extent. So then we have the internet benefit of a non-diffractive Acrosoft, which is the IQ Vivity, which is currently available. It has got a 2.2 mm wavefront. So in the same optic, you have a single central 2.2 mm wavefront shaped optics. It actually stretches instead of focusing at specific points. This will stretch and shift the wavefront. It avoids the light splitting. So behaves nearly like a monofocal lens and giving a lesser halo and glare to the patient. And it is one of the first of its kind which came into the market. So it delivers distance intermediate and functional near vision, as we say, to the patient. And the monofocal visual disturbance profile is there, not much of visual disturbance. And non-diffractive wavefront shaping technology stretches and shifts the wavelength, as I said, to create an extended focal range. Then we have this another lens which is also available, which is similar but not the same. You have a central axial in the Swiss advanced IOL. You have a central axial which focuses a light for the intermediate and the near, and the larger refractive zone which is available for us for the distance. So the glare and halo is reasonably reduced in this. So it's as I said, it's a single piece foldable multi-zone refractive aspheric IOL with a 360-degree square edge, a closed loop haptic. And it has got a 6 mm optic zone, and a total diameter comes in 10.8 or 12.4. It's made from hydrophilic acrylic material. And as I said, the central axion stays. The 1 mm aspheric zone occupies the center of IOL surrounded by a 6 mm refractive ring. So the basic disadvantage which we should remember and convey to the patient is that because of the light splitting, however advanced we go, it may vary from, there will be a reduction in contrast sensitivity. There could be glare and halos, but not always, because practically when we inquire a lot of patients, they say the glare and halo is less when we go in for lesser number of rings. So less satisfactory visualization of fundus could be there, but in the newer advanced IOL like the Vivity or the Lucidus or the expanded or extended monofocal, which we will see, we are not facing so much of difficulty in the retroretinal procedures. And the multiple rings really requires a good visual cortical neuroadaptation for getting adapted to the glare. So reassurance is should be at its peak. And then, as we know, we'll go ahead with the biometry, which is important for going premium. So word on accommodating IOLs as well, though it is not very commonly used, at least in the majority of practice which I have come across in my 20 years of surgery in ophthalmology, is but we should know about it. A truly accommodative IOL actually would be the one capable of undergoing a progressive change in its power Many designs were postulated with a single optic, dual optic, change in shape of curvature, change in refractive index. All that is still being tried and tested, but with evolving newer refractive diffractive design in multifocal, the accommodative truly has taken a setback, I would say. And then some of the drawbacks why it probably could have gone in for a setback is the ciliary muscle may not be strong enough to power the lens. So there was a failure of accommodation due to fibrosis or a capsular opacification, and there could be an overinflation syndrome or a deflation syndrome. So these are quite a few things which, though the accommodative IOS came a little earlier, they didn't advance to further extent as what was the advancement in the trifocal and the extended monofocal mechanisms. So this is a word on extended depth of focus lenses which are available. Though the pinhole effect, small aperture design, and bioanalogic IOLs are all there on the theory, the most commonly used extended depth will be in the Cataract technology. It forms a stepped structures whose modification of height and spacing and profile of the Cataract extends the depth of focus. So these design feature in combination with achromatic technology and negative spherical aberration, it corrects and improves the simulated retinal image quality without compromising depth of field or tolerance to decentration. These are little forgiving lenses. Even if you go a little myopic or there is a slight decentration, the lens really do forgive, which we see in practical things. So this is one of the lenses, which is Symphony IOL, which has this Cataract technology and extended depth of focus. And now is another new lens which has come up. These are called enhanced monofocal. The three important things which are being studied are the Technis Eyhance, the Hoya Impress, and the Isopure lenses. The enhanced monofocals are aim of providing excellent visual acuity for distance, the same as conventional monofocal, while improving intermediate distance performance without the side effect of traditionally caused by multifocality. Just as a model design, I would say, this is a modified aspheric anterior surface, this Eyhance, which can create a continuous power profile from periphery to center, providing a stretch in the range of vision and improving vision for intermediate tasks. So then we need to see the toric IOLs. In all these premium, we also have to remember that we need to correct the toricity if we have to go premium, and the goal generally is to correct 1 degree of astigmatism or more in patients undergoing cataract surgery at a corneal plane. And then after knowing all the lenses which are available, now we should see what next. We know all these are available. How do we put it to a patient? So we need a precise biometry when we go for premium eye surgery, and we need to have a zero predictive error in our biometry. And we should know what can go wrong and how to correct. So there's one article which was really attracting me, is the adoption of non-contact techniques and creative problem solving by biometrists can actually improve the A-scan results. When we are going premium, we need to actually invest a little bit premium, and definitely the investment is worth it. So there's so many optical biometers available with a wide range of pricing. And one of the study was good. It was very heartwarming to see that no significant difference among the refractive outcome based on measurements of optical biometer. So whatever be the optical biometer, if you can invest from a better company, the results are not too many. It's not too different. So it is worthwhile when we go premium to invest in a optical biometer and upgrade as we go along our practice. So, and then that is about the procuring the instrument. Now we come to see what is very important. I'm going to say the topic is very vast, so I will just say what is very salient about measuring in case of a premium. So the first thing first, so the K reading has to be taken first. You perform a valid biometry. The first thing should be the K reading. If there is a contact lens, try to be ask the patient to remove it for 2 days at 2 weeks, and then measure it after a natural blink. Measurement should be done before any measurement which has impact on the cornea, like tonometry or a dilatation. And KFM corneal topographer, generally we don't encourage, because it is mostly the SIMK. And regular optimization is also very important. So as we know, keratometry, it has to be done before the axial length. I again want to say this. And though we have manual keratometer, auto keratometer, and topography, the preference would be, because of the precision, would be to go for a optical biometer calculated keratometer and correlate it with the auto K or the manual K, and just have a specific reading. So The eye has to be the point which we should know. The eye should be really open well, and mark should not be wholly or partly obscured. The measuring mark has to be really centered, and peripheral mark should have sharp halos. So this is also about the ACD depth measurement in an IOL master. And then we can further refine by knowing about the posterior corneal measurement and the posterior corneal values. I'm not going to detail for the sake of time. And then we should know what could be the source of error. So unfocused eyepiece, failure to calibrate. So when we go premium and we get a better instrument, we should also know that we should calibrate it very frequently, as per the recommendation at least. And you can also have a poor patient fixation, which can lead on to error. So the patient has to fixate well. Ocular surface has to be corrected. And if there's any drooping eyelid, we need to look into that. And irregular corneas can give a rise to errors. And then comes the axial length. Minimum, if it's I'd first talk about the optical biometer. In this, minimum of 5 measurements within a 0.005 mm is required, and we have to aim for that. And also look for the SNR ratio, signal noise ratio. And you also analyze the wave graph if you are having. So these are things which will help us avoid any error. And always validate your axial length. So axial length difference between both eyes, if it's more than 0.3, you need to repeat. If the axial length measurement is less than 22 millimeter or more than 25, repeat once by repeat a different technician as well, even though it is the optical biometer. If does not corroborate with patient's refractive error or glass, again repeat, or if the patient has a poor fixation. And we should know the basic difference between an ultrasound and an IOL master or a optical biometer. There will be a minimal difference as published in many articles. And it could be the difference in axial length between immersion and appellation can be up to 0.036 because it is from the place where it measures. See, the ultrasound measures from the outer surface of inner surface of the retina, whereas the IOL master takes the reading and the reflection at the Brooks membrane. So, and also, what if we do not have a optical biometer? Should we never go in for premium? No, that's not the case. When we are building our practice, we can still have it with a good immersion biometer. Most of the biometers are now coming up with an immersion option as well. So knowing how to do a proper immersion is also important. Very specific point which I would mention is placing the probe rightly, looking for the gates exactly, and look for the peaks. If the peaks are normal in the waveform, then that is a trustworthy measurements. As so these are the error points which we should be clear when we are using an immersion biometer. And that also can be used if done by a good technician. So the training of technician is very important. The importance of a optical biometer is cannot be neglected when it comes to abnormal places. Like nowadays, we are seeing a lot of patients who have undergone even refractive surgery coming in for a premium IOL surgery. So having a optical biometer and knowing the calculations and the formulas really makes a lot of difference in going premium. So as was told earlier, 20% have got corneal astigmatism also. So we should know about correcting the toricity as well. So though we have a lot of evolution, which formula to use? So to give a very straightforward or a kind of straightforward answer, which will make life easier, the third and the fourth generation formula are definitely superior. So whenever available, the idea is to use this. And we do have a lot of theoretical and other formulas which are currently available. And these are all the parameters which each of the formula takes it into consideration. The form and this is one which I would like to go a little deep. Nowadays, the Barrett's 2 is available in a couple of the optical biometer which we have, even the lower cost ones. So going in for a Barrett's 2 or using the ASCRS calculator online for complicated calculations like post-refractive surgery, post-ICL explantation with refractive option. We can use an online calculators as well for calculating the final intraocular lens power. In our practice, we generally go with the SRKT when it is a normal anatomy, and we use a Barrett's 2 if there is any abnormal or a long axial length anatomy, and also the ACRS calculator These are the three things which we use and which I have used and got pretty very good results with not much of complaints from the patient. So SRKT, if it's almost within normal calculation, Barrett's 2, if it is available, and ASCRS calculator online for post-LASIK or post-refractive error corrections. And some of the links which will be useful for us to do more about the recent advanced formula, I have tried to share. And when interested, we can go through this to know more on this. So, and the zero prediction error has to be kept in mind, and pre-op assessment of clinical entity is very important. Identify irregular astigmatism. These are the cases which we need not go for multifocals, but we can still go for the enhanced monofocals. Macular pathology, zonal weakness, and pre-op management of ocular surface should never be forgotten. Patient has to be told, identify the appropriate refractive target. Emetropia is in most cases. And the transfer of skill and knowledge, educating the optometrists and teaching them to do can never be underestimated. And you have to periodically upgrade the system to go in for a zero prediction error. And some of the toric IL calculators which are good for the toric calculation are as in Barrett's online calculator or the company itself for practical usage. If you give them the value, they will calculate and give it back to us, reducing our stress. And most of the time, these are good enough to put it into practice. And the residual error as given will be available if the other parameters like A scan and K readings are correct from the IL, from the optical biometer. So other pre-op error which I would really want to stress on when we go premium is marking the IL power. When the doctor marks the IL power, we should be really careful because we have had problem when the marking has gone wrong or appropriate ad is not chosen. Or example, feed the right data for any online calculation and personally check whether the axis is flipped for K reading measurements. And after LASIK, as I already said, using a specific formula, the ACRS calculator really comes into play, and the average reading which they give, if it correlates from the other biometry devices, we going in for that is a safe option. And validation is more than one diopter difference, you need to revalidate. More than one diopter of expected measurement, revalidate. Prior keratorefractive surgery and calculated power is not between 20 and 23, please revalidate. And some few other tips is patch each eye for better fixation when you measure the other eye. Scan both the eyes and compare. Gain settings have to be low, have to be monitored when it comes to a contact or an immersion biometer. And then comes the surgery. So we have seen what are the IOLs available. We have seen about the axial, we have seen about measuring, and we are now going to see the precise surgical technique. And even if it's a mature cataract, it is possible when the surgical technique is planned correctly. You understand the ultrasound energy and the fluidic circuit. And surgery basic should be determining the correct power and axis, intra-op marking, dialing and alignment, post-op assessment, and then you have to really know how to troubleshoot. So having your own SIA data sheet was important earlier, but now with the Barrett's calculator, having it as a 0.1 also is sufficient and it works well. Preoperative marking, generally done with patient sitting in under topical anesthesia, mark the eye, put the patient with the head on the forehead. This is a slit lamp marker where you have the slit lamp placed at marker placed at 180, and then marking done for the vertical, and then rechecking whether the marking is aligned or not, and then so this is how we can mark. Then this, I practice this and this has worked good in my hands. The other, we also have other markers which are available for prior to cataract surgery. But during cataract surgery, the round marker and the astigmatism axis markers comes very good. But each of the cataract surgeon can have their own preference. And what works with them, for them, you can go ahead and do that. But it's important that you mark pre-op and you mark post-op. And then is the planning of incision location, rexus, polishing of PC, complete viscoat removal, recheck the position after removing the speculum, and always wait for 3 weeks to 3 months before rotation. So, couple of factors affecting toric IL rotation. The IL material, so it's very important to choose the IL material when you consider a toric toric lens, and overall IL diameter. So in myopics, As I told, some ions come with different sizes. Like, for example, Lucidis comes with a 10.8 for a normal eye, and you can use a 12.4 if it's a very high myopic eye. Like, I have used lenses up to uh, a very lower order also for topical. And the haptic design initial concept was loop haptic prevents early rotation, plate haptics prevents late rotation. And we should be aware that every degree of rotation decreases cylindrical correction by 3.3%. And surgery, if you have advanced surgical markers, you can have it, or at least display where the lens has to be there on the board as you operate, and then it will be aiding us in the placement. So whether it is toric or whether it is premium or anything, we prefer a topical anesthesia. And if it is toric, please mark. The center of fixation is marked before giving the block. And marking, as I said, pre-operatively mark on the slit lamp, and post-op during intraoperatively mark before you start, and before the IL placement, the marking will help. With the patient fixing in the center of the microscope, right, both incision and axis of placements are marked with a circular marker. And the technique of surgery, the rexis has to be 5.5 millimeter, plan around regular rexis. Insertion of lens is aligned a few degrees off the marked axis. Try a complete viscoelastic removal. So this is a rexis and phaco happening, and the marking is visible. Distend the bag. Mark with a marker. This is for a toric. The other things are as in for a normal IOL implantation. The rotation and the placement is very important. Whenever you rotate, always do a rotation with a counter traction. So do not rotate only in one direction. If you are marking, you rotate in both the direction, above and below, and align it accordingly. And wash the visco. So the chamber is sealed and air may be injected for tamponade. This is just to show the marking, pre-op marking, which is the dot marks, and the intra-op marking, which will help us even if the pupil constricts. And this is how we mark with a round marker and this axis marker. This is very easy and it is very quick as well. And if we do not have a guided system. And this is just a multifocal lens in place. Similarly, when it's a plate haptic, the rotation is slightly difficult. Always rotate above and below. Never rotate only one direction. This is for placing, and this is a multifocal toric in place. So this is premium. And this is just to show you how we wash behind the lens also. And or you just tap on the surface of the lens, most of the visco will come out. And the previous one was a hydrophilic lens, so it's very important to seal it well to the PC. And this is washing beneath the lens and sealing the chamber. So this is a Virion platform where this is highly advanced, wherein we have a marker. This will help us intra-op incision guide, and then you have the intra-op orientation guide as well. And this is with the premium lens in place. So the last but not the least is the patient selection history and counseling. You need to really realistic picture should be portrayed to the patient whenever we go premium. Else you will always end up having a discussion after the surgery. So understand the previous patient's goal. We used to have a simple lifestyle questionnaire wherein we also mark the the psychology of the patient, whether they are easygoing or a perfectionist. These questionnaires are available. You can adopt them in your premium practice. And then you have a cataract and refractive lens exchange questionnaire as well. What is that? If the patient is okay for having a specific thing. And 1 more minute. Steps to success, whether perform a very good preoperative examination is important. Few contraindication where we should remember that we should not place the IOL, especially multifocals. And choosing the IOL is also important. A simple flow chart which will help us to choose which is good for the patient. You always have this in mind when you go premium. And post-operative management is very important, especially to fine-tune and customize. Take-home points is patient counseling is an art. And for premium, it is very important. Appropriate choice of IOL implantation, good care and reassurance. Under-promise and over-deliver. Indicate need for rotation and for stability if it's a toric. And we have to be very bold. We should post-operatively treat the patient and not the readings. Sometimes I would even only see the vision of the patient. For our understanding, we may see, and we always have a form by which we will assess what are our results after 1 month or after 6 months to know where we are going wrong, which IOL is better for us, which gives us no glare or no double vision, and then implement in our practice. So I would like to end by saying, have a great day and always have a great surgery. And many thanks for this opportunity to be on this podium. Thank you all.
Thank you, Dr. Preeti, for that excellent exposition on premium IOLs. And the point that you've driven home is that with the plethora of premium IOLs available, it's important to customize these IOLs to the needs, to the lifestyle, to the profession of the patient. So my question to you is, if you could just detail the patients in which these premium IOLs are absolutely contraindicated, that we do not implant.
Sure. So the patients, we can say according to the eye profile and according to the systemic profile, I would like to segregate the patient. According to the eye profile, if the patient has got advanced diabetic retinopathy with a compromised macula or any retinal pathologies and advanced glaucomatous cupping, I would definitely not go in for a premium multifocal IOLs because these will definitely reduce the light entry into the eye. As we see that there are a lot of splitting of the distant vision, light for the distance intermediate, they will reduce the contrast sensitivity. So definite no for all these multifocal IOLs with the multiple rings for patients with advanced diabetic retinopathy or even a moderate diabetic retinopathy with a macular edema or a ERM which is present in the patient preoperatively causing a significant decrease in vision. And for patients with advanced glaucoma, more than if the patient is having more than a 0.6 or 0.7 cupping with not on medication or very notwithstanding any proper treatment, like compliance is poor, wherein you have to compromise if you put in a multifocal, because people demands are too much these days. Even people with advanced glaucoma comes in asking for a IOL without where they don't have to wear glasses. So we need to be very clear with these patients and not go in for a multifocal or a trifocal IOL specifically. You can tell them that you can go for an expanded or an extended enhanced monofocal like an IHANS or an Impress, and tell them that you will have to wear glass or do a monovision correction for such patients. Do a little minus in the non-dominant eye and put a emetropia in the dominant eye. That would work, but you should always, when you go premium, the amount of patients and the chair time you give for the patients is most important. So these are the absolute contraindication with respect to the retina and the optic disc. Coming on to the anterior cornea, irregular scars, we will not be able to put it. We will be finding it very difficult to do it in a severe dry eye patient. Better not to go in for any of these multifocal or trifocal IOLs. And any abnormality in the anterior chamber, like eye syndrome or a subluxation or anything, it is better not to go in for the trifocals specifically. In all these cases, if they want a little premium, you can probably go in for the extended or enhanced monofocal as they call in for. So these are my absolute contraindications for trifocal and an enhanced or a.
And thank you. Yeah. And as you mentioned that halos and glare is a problem with these lenses in some patients. So would you go in for people who are younger and driving at night? Do you still go in with these, the extended depth of focus lenses for these patients before
Yes, I would
after counseling?
go. Yes, I would definitely go. As I said, when we explain to the patient that this is the plus and minus and give them an option, which one they prefer, I would, if the patient is willing, I would definitely go, because few of these lenses, like for example, in my practice, the lens like Lucidus or a Vivity or even the Panoptics, to mention a few, but not with any financial disclosures, are actually not causing too much of glare. As I showed you in my last thing, we keep analyzing which is giving more glare, which is giving more halo. But if there is a previous refractive surgery, so like I have done patients who have undergone an ICL implantation followed by a LASIK implantation, who has come in for a premium IL, is around 40, 50 years of age. That was my toughest patient for a calculation, basically, and implantation. And I could achieve a 6x6 and 6 and a happy patient by giving a lot of time for thinking about what he wants. Now he's willing for the other eye as well, wherein I have to do the same thing. There is a post LASIK, post ICL. I'm going in for a panoptic toric for that patient. That's what I did for the right eye. The patient is happy. The chair time, I feel it's very, very important. And you assess, as I said, are they really driving at night? Or in India, they have an option of having a driver. When it is patients from abroad, I clearly tell them that it will be very difficult for you. And if you're somebody in the night profession, go in for an extended or enhanced monofocal rather than going in for all these trifocal lenses.
Thank you. Thank you so much. And my last question is, does your choice of, the choosing the lens from the biometry, does it vary from the patients? Like, do you use the first myopic reading, or do you prefer to keep some of them emetropic, depending on the different lenses? Or do you always target emetropia?
For the dominant eye, I always do a whole card test when I'm going in for that's a simple test which we can do. The size of the hole, everything is mentioned online. We can have a hole with us. I ask my optometrist to always put in which is the dominant and non-dominant eye. So in the dominant eye, I always aim for emetropia only in all these multifocal lenses. I am not so specific. Suppose it comes as 0.05 and the next reading is as minus 0.21. I would go in for a minus 0.21, but not if it is a minus 0.50 or something like that. So I aim the dominant eye to be definitely emetropic, because even a little off will have a issue for us. But the non-dominant eye, I will make it a little myopic if I feel that the patient is not reading well or he has got some trouble, or I will even mix and match. I have done a couple of mix and matches also. The end goal is a happy patient. So
True.
for that, we apply those things.
Thank you so much. And you have reiterated very well that proper patient counseling, spending a lot of time in, asking the patient about their needs, doing multiple examinations if required, is the key to success in building up a premium IOL practice. So thank you so much. And with that, we move to Dr. Pal. Dr. Pal, are you ready with your slides? So Dr. Pal will be speaking to us.
Yes, I am ready. Yes.
Cataract surgery. So we look forward to your talk.
Now I am sharing my slides. It's
yes,
okay
please.
Or not?
We can't see your slides as yet.
Just wait.
Okay. I would also request the panelists, all of you who are present here, if you have any questions, any comments, anything that you'd like to share, you're most welcome to please join in.
Hello, my slides are visible or not?
Yes, they're visible now.
Now it's visible. Okay.
Yes.
And thank you. And sorry for this technical problem. So my topic is small incision cataract surgery. And SICS is an excellent manual and low cost technique for individual as well as for mass cataract surgery. And what is gold standard cataract surgery? As we know, phacoemulsification with foldable lens implantation is gold standard cataract surgery in modern era, because it have a small self-sealing incision, sutureless, bloodless, and nearly not inducing post-operative astigmatism. Even it reduces the pre-existing refractive error and very early rehabilitation. But unfortunately, it's a expensive, machine-based, required highly experienced surgeon and having deadly complications like endophthalmitis and damage and nucleus drop. SICS is having nearly all advantages of phaco along with other advantages, as this is a manual, less expensive. It's a very fast surgery, suitable for all type of cataract, small learning curve, and less deadly complications, and better wound integrity than phaco in case of clear corneal incision. It's a manual surgery, manually performed surgery, no specific machine required except an average microscope, or sometimes it may be possible on the magnifying loupe also. It is a very less expensive because cheap instrumentation is required, cheap labor is required, materialistic cost is very cheap, and per surgeon yield is more. For example, it required only 3 specific instruments costing less than 150 rupees, and it is also disposable like crescent knife, 15-degree angle side port blade, and creatome, and rest other instruments are as usual cataract instruments. It's a fast surgery because less instrumentation time is there, and operative time is also very less. So it is very suitable for mass surgery, and it is suitable for all type of eye, which is the safest cataract surgical technique. Any type of cataract like mature, hypermature, black, brown, subluxated, traumatic, posterior polar, they are permissible in all type. Any eye, either small eye, deep-seated eye, complicated eye, small pupil, general weakness is there. In all type, you can perform SICS. Any person are fit for SICS except some younger children and mentally retarded person. And fortunately and unfortunately, these conditions are more common in low socioeconomic groups of person who are most commonly operated in the camp or as a mass surgery. These all conditions are permissible. This small incision cataract surgery, the learning curve of small incision surgery is lesser than the phaco, and in very less time, anyone can mastering in the small incision cataract surgery. There is less complication as shown in this table. In phaco, there is thermal burn. Chances of thermal burn is more. Endothelial damage is more. Nucleus drop may be possible in phaco. It is very less in small incision cataract surgery. Post-op infection is also less in SICS because only integrity is better. And post-operative central SK is more in phaco, but peripheral SK may be possible in SICS, more in SICS. Wound healing is better in SICS, but post-operative estimation is definitely more in SICS, but it is nearly equal to the phacoemulsification. Wound healing but earlier in the phaco than the phaco in small incision cataract surgery, because it is situated in vascular area. And post-operative astigmatism, as I have told you, if outer lip of tunnel is frown or V-shaped and within astigmatic neutral funnel with natural approximation, that means not apply suture or any other or lacerated wound, then the result are as good as phaco. Specific advantage, if during phaco surgery any complication occur, it's very easily convertible in the small incision cataract surgery without any significant visible effect. So it is a prestige protecting type, and there is nothing effect on the patient. Now come to the steps of small incision cataract surgery. Some important tips and tricks. First one is step is radial suture, and second conjunctival flap formation, tunnel formation, then side port formation, wound entry, capsulotomy, hydroprocedure, nucleus prolapse in AC, nucleus extraction, cortical wash, lens implantation, viscoelastic wash, and wound closure. So now come to the bridal suture. It's optional. Most of surgeons not prefer to give a bridal suture, but for the beginners, it is actually essential. It provides a steady eye wall and helpful during nucleus and cortex extraction. Conjunctival flap formation. Here, peritomy should be only up to the proposed conjunctival flap, not extensive peritomy is required. And pinch the conjunctiva at right corner of flap and give a nick just away nearly 1 mm from the limbus. Insert scissor with closed blade. Here, closed blade is very important. Not give a small nick, but you insert the scissor with closed blade. Throw nick up to the left corner, then open scissor to perform peritomy. And pull conjunctiva tightly and cut limbal attachment of the conjunctiva along the Tennant's capsule. Here, pull conjunctiva tightly. If your conjunctiva, you hold your conjunctiva loosely, then some conjunctival part is leave at the limbus. Expose bare sclera by retecting it with tenon and conjunctiva, both retect here and expose the sclera. Cautery is optional. Some all are not using, but some persons are using cautery. This is a figure showing the conjunctival flap formation. First one is proposed this flap. In second, you pinch the conjunctiva. In third, you insert a close scissor and reach up to the left corner, then open it and cut with tightly pulling the conjunctiva. Then tunnel configuration. Length is depend on the size of the hardness of the nucleus, but it is a nearly 5 to 7.5. Width of tunnel is nearly 2 mm, 2 mm on the scleral side and 1 mm on the corneal side. So total depth, total width is nearly 3 mm in the center. Depth is nearly more than half to two-thirds thickness of the scleral thickness. Outer incision is maybe smiling type, straight type, round or V-shaped or chevron type. Inner incision is nearly at 1 millimeter on the cornea. Inner lip should be parallel to the limbus. Inner lip should be bigger than the outer lip, and shape of tunnel should be like inverted funnel. And tunnel should be triplanar in nature. As shown in this figure, in first figure, there is a site of the tunnel. In second, outer lip is showing, and inner lip is bigger than the outer lip, and two wall, lateral wall and medial wall. And width of this incision is, this tunnel is nearly 3 mm and length is nearly 5 to 7.5, depend on the size of nucleus. In another figure, cross section of the cornea, the triplanar nature of the tunnel is visualized here. Then types of outer incision, they are first one in first figure, they are straight one, then smiling one, and round shaped and chevron shaped. Then characteristics of these incisions as shown in this figure, this round and V-shaped incision are are good incisions, and they are better result with least astigmatism, but they are difficult to formation, and they are also more stable, but they are difficult to formation. Now come to the how you make a tunnel. First, in first figure, there is a proposed tunnel is there, and in second, we just try to find out the plane of the tunnel. So use a crescent and give a outer incision nearly half thickness of the sclera, prawn shaped, and then engage the tip of crescent in the tunnel and maintain the contour of sclera and cornea and reaches up to the end of the anterior end of the incision. And during this period, you are doing the wriggling movement at the tip of the at the fingertips. Okay, and do a wriggling movement and first try to reach the up to the anterior border of the tunnel. And when you achieve this plane, then you doing a sliding movement at the level of wrist and moving either side. And when you are reaching at the corner, you again doing a wriggling movement on the tip of your finger. And in this way, you complete the tunnel, but not open yet. Then how you make your side port? It's first you remove radial suture and make with the help of 15-degree angle side port knife. It is a uniplanar insert nearly at 45-degree angle from the corneal surface. After piercing, corneal direction should be parallel to iris plane, and width should be to accommodate IA cannula or irrigation aspiration cannula. Width should be accommodate this. And use of capsulotomy is first is optional. It is optional. Some persons using the side port knife, or some are using the main tunnel to fill AC with the visco, AC wash, and for hydration. This is side port formation. In first figure, here is proposed side port. In second figure, you just use a 15-degree angled blade and make a tunnel and increase the size of this side port to accommodate the IA cannula. Now come to the wound entry. Entered with the help of keratome. Insert keratome in tunnel along the contour of sclera and cornea. Tip of keratome reaches up to inner edge of the incision. Hold globe against tip of keratome, means toil into 6th position. Keratome position is a toil o'clock, and you hold the globe at the 6th position. Raise heel of keratome in same position till dimples with radiating fold form on the cornea. Pierce cornea in center. After complete entry in AC, open tunnel by to and fro movement, but cutting while entering. And in this way, you complete the tunnel. Here the figure is showing the AC entry. Here you have a keratome which is reaches up to the anterior border of the incision, and then you raise the heel and observe the dimples over the cornea, radiating fold and dimples over the cornea, and then you pierce the cornea, and by moving to and fro movement, you cut the side walls when you are entering inside the tunnel. Now come to the capsulotomy. First, you inflate the chamber, and any type of capsulotomy is permissible in the small incision cataract surgery, like can opener envelope type and CCC with their merit and demerits. Like can opener, it is easy for SICS beginner, but the loss advantage of intact bag, hydrodissection, delineation, or hydroprolapse should be avoided. Prolapse of nucleus is difficult and should be done very gently. Envelope technique, it is easy and take lesser time. Safest in hypermature or Morgan type cataract. Most of cortical matter was during hydro procedure, and it is suitable for mass surgery. After lens implantation, remaining capsule need to remove, and capsulotomy is not good centered, and after some time lens may be decentered in such type of capsulotomy, so it is not very good one, but it is good for the mass surgery. Then come to the CCC or continuous curvilinear capsulorhexis. It is safest and provide intact bag. All type of hydro procedures like hydrodissection, delineation, prolapses are safely performed. All type of nucleus prolapses are possible. It is difficult to learn, but and in case of small incision surgery, capsulorhexis should be bigger than phacoorhexis. It's very important to accommodate the nucleus. Its size should be bigger than the phaco. Its size should be big enough to accommodate prolapsing nucleus. Then technique to nucleus prolapse. This is the delivery of nucleus in the AC. So you have various procedures, but important one is hydroprolapsis, wheeling, lever or tire technique, bimanual technique, and rock and roll method. Hydroprolapse, it is most common and most of surgeons using this hydroprolapse. It is safest one. First, remove some amount of viscoelastic from AC to reduce resistance during the nucleus prolapse. Then insert hydroneedle 1 to 2 mm under rhexis margin, and tip should be toward periphery. Push hydro gently till one end of the nucleus and prolapse from rhexis margin. Rotate partially prolapse lens to complete prolapse with same cannula or after inserting visco with visco cannula or a doiler. Here the diagram is showing the hydroprolapse. This is the tip of needle facing towards the periphery. You push the saline, and when you feel resistance, you just stroke in the center. And in this way, when the one end of the nucleus is prolapsed, then you rotate it with the help of your same needle, or you use a visco and then rotate again and prolapse the nucleus in the AC. Now, second technique is wheeling technique. In this method, one edge of nucleus is hooked with Sinskey hook. And here, the important thing is that you keep the tip of your dialer in the center of the rhexis, not on the margin of rhexis, and then move periphery along the contour of your nucleus and reaches up to the equator. And when you are at the equator, then you hook the nucleus, so it is very easily prolapse at one end, and then you rotate it and prolapse whole nucleus in the AC. Now, bimanual method, when journals are very weak or lens is very hard or big, then you use bimanual method. Here you use two instruments, one hook to fix one edge of the nucleus, with next hook elevate another edge of the nucleus. And important thing is that you don't put the tips of these instruments on the rhexis margin, but you put on the in the capsule and move along the contour of the nucleus. Rock and roll method. Here first feed nucleus in the bag with hydro procedure and rotate nucleus with that horizontal plane, and as shown in the figure, you rotate whole nucleus and prolapse in the anterior chamber. Then nucleus extraction. There are mainly two methods. One is in complete nucleus is removed, and in second, you reduce the size of nucleus and then extract the nucleus. So first one, their techniques are irrigating wire vectis technique, Checo sandwich technique, Blumenthal technique, fish hook method, or visco expression. So now first come to the irrigating wire vectis method. Here you use a irrigating vectis. So they have 3 ports on the tip, and hold the brittle suture. Insert irrigating vectis, go under the prolapsed nucleus and keep nucleus on the vectis ring. Then pull nucleus along with vectis and engage nucleus in the tunnel. When your nucleus is engaged in the tunnel, pull brittle suture, press lower lip with the practice and push hydro. So hydro pressure push engaged nucleus from periphery towards open but engaged tunnel. And in this way, you prolapse the nucleus with the hydro pressure. As shown in this figure, here you have a wire vectis. You keep the nucleus on the wire vectis, irrigating wire vectis, and then you engage the nucleus in the tunnel, and same time you pull the bridle suture, press the lip, and push the hydro so that your nucleus is pushes from inward to outward by the hydro pressure, and they are not rubbing over the cornea or the PC. And in this way, you remove the nucleus outside from your eyes. Then sandwich method, the nucleus sandwich between wire vectis and Sinskey hook and drag nucleus through the tunnel. In Blumenthal technique, it is the oldest one technique and the most popular technique. Use AC maintainer and lens glide. Here, you first insert lens glide below the nucleus and keep the nucleus over this lens glide, and same time you maintain AC with AC maintainer and increase the border height to increase the hydro pressure, and same time you press the glide inferiorly. In this way, you open the tunnel, and with the hydro pressure, your nucleus is extracted from outside from your eyes. Then fish hook method, it is a very popular method in Nepal side, and various surgeons are using this fish hook method. It is very suitable for envelope capsulotomy type. A fish hook introduced below the nucleus, which is made by the 30 gauge needle, like a hook type structure is there as shown in the figure, and then engage nucleus in the center with hook and pull the nucleus along the tunnel, and just tunnel is pushing with the help of same needle. Okay, and in this way extract the nucleus. Then Visso expression, sometimes if nucleus is hard and it is very hard, then you use a, instead of hydro pressure, you use a visco pressure and you use visco expression. Then come to technique to reduce nucleus size in anterior chamber. It is a phaco fracture at the exit of the tunnel, pre-chopper, phacofragmentome or nucleotome or bisector, and phaco fracture with wire loop. This is known as snare technique. So first one is phaco fracture at the exit of the tunnel. In this case, if your nucleus is bigger and it is not possible to deliver in one bowl, then you come and engage the nucleus up to the tunnel, and then you hook your wire vectis and crack the nucleus in between and remove the half piece of nucleus. Then you again go fill the visco, rotate the nucleus, and so that its smaller surface, smaller part is facing towards the tunnel, and then you again go with the wire vectis and remove the remaining part of your nucleus. Then pre-chopper, here you are using some important type of instruments. Go and crack the nucleus in the AC and then remove one by one these pieces. Then nucleus bisector, here you again use the instrument which bisect the nucleus in the AC. So first you go, either you are using wire vectis or you are using a plate type system, and go below the nucleus and hold nucleus on this, and then use the bisector to bisect the nucleus by pressure. And in this way, you bisect the nucleus and remove pieces one by one. Then phaco fracture with wire loop or snare technique. Here, as visualized in the figure, some wire is passes through a needle and make a loop and engage the nucleus in the loop, and then pull the wire to dissect the nucleus into two pieces, and then remove the nucleus in one by one pieces in one time. Okay. Then cortical wash is most of loose cortex extracted by pressing lower lip of the tunnel. Remaining cortex first removed from 6 o'clock by the main tunnel, and then temporal and nasal cortex respectively. So first remove the cortex, which is very easy to remove, and 6 o'clock cortex are very easy to remove. In last, you remove the upper nasal and submedullal cortex through the side port, because if you remove in the upper nasal cortex and submedullal cortex with the main tunnel, then your chamber is flatted and you may go for the BC rupture. So you use during this period, you use the your side port incision. So your chamber is full formed, and you remove these cortex one by one. Then lens implantation, insert leading haptic in the bag. So first you hold the lens nearly at 2/3 and 1/3 of the optic of lens with the McPherson forceps, and then insert leading haptic in the bag. First, when your leading haptic is go inside the bag, then you push trailing haptic inside up to 2/3 lens pushed in the AC, and with the help of dialer, rotate and insert complete lens in the bag. Visco wash, it is a important one, and insert IA and just press the lower lip of either of the opening, and sometimes you need to stroke on the center of the lens, and in this way you remove the visco. Now wound closer, it is an important one. Hydrate only side port. Main tunnel is not required to hydrate. Push hydro in corneal stroma through both corner facing in lower and upper direction, not towards the center. If you push towards the center, then your cornea will become heavy. So you push the saline or fluid towards the upper or lower side and remove cannula without pressing the lower leg. If AC loose, not rebound field, then some hydro you may push from outside of the side port lip, because it is working like a valve, and if you are pushing from outside, then this fluid go inside, but it is not coming outside because your cannula is outside, so you are not pushing your lip. Sometimes you may use air to maintain the AC. In last, you check the rebound field of the AC, and if it is okay, that means your this your AC is well formed and you are right. Then complications of the small incision surgery. As per of complications, these are usually first one is laceration of tunnel or button holing may be there. If your crescent is not very sharp, or if you are not up to the right depth, or you are cutting multiple times, then you lacerated your wound. And sometimes if it is a thin, then button holing may be there. In such conditions, if your AC is not open, then you close this site and remake a incision at another site or postpone the surgery. But most of time we are using another site and making another tunnel. If premature entry is there, then do all the procedures very gently, and in last apply suture. If iris prolapse, iris shaping or dialysis is there, this is maybe due to the laceration or due to the uneven tunnel. In such conditions, you in last you apply the suture and perform all these steps very gently, and most of time you use the side port. Sometimes partial nucleus is extracted and partial is remain in the AC. In such condition, you do not try to remove the nucleus on same hole, but you go and again push the part of the nucleus inside the AC, then apply visco, and then move the nucleus, rotate the nucleus so it's a small size is facing towards the tunnel, and then you use the wire vectis to remove the part of nucleus. If intraocular hemorrhage is there, check the where is the hemorrhage point, and if it is inside the eye, then you apply some air for some time, and if it bleeders are closed, then you perform your surgery. If bleeders are present on the tunnel, then you apply some suture. If general dialysis or back prolapse is there, then you perform all these steps very gently, and maybe use CTR or go for the if back prolapse is there, then go for the secondary IOS or anterior chamber IOL. If PC rent is there and no vitreous prolapse is there, then assess the size of PC rent, assess the rim of your rexis, and implant the PCIOL. But if vitreous is there, then definitely you cut the vitreous and reassess the rexis margin and size of the rent, and then implant the intraocular lens as required. Partial or complete nucleus drop. In such cases, you refer this patient to your BR surgeon after observing the patient. Rest complications are as usual as cataract surgery. Post-op complications are AC not formed. In this condition, you reform AC, and if required, apply suture. Post-op hyphema is there. If it is small, then go for medicinal treatment. If it is a big, then go for the wash. If SK is there, go for the medicinal treatment. Assess the DM condition, and if it is DM detachment is there, then repair the descemet membrane, and in this way you manage these SKs. And if iris prolapse is there, insert the iris and reapply the suture and reform the your chamber. In conclusion, SICS is an excellent low-cost surgery, ideal for mass surgery, and very safe even an average experienced surgeon. Thank you.
Thank you, Dr. Pal, for walking us step by step through the intricacies of small incision cataract surgery. Very well expounded. And I'm sure it has been a very informative talk for everyone. My question to you is that since you've been teaching so many postgraduates and, performing this surgery over the years, what do you think would be the top 3 challenges for a beginner who's starting out to do this surgery? Where do they go wrong? Which are the steps, and how should they overcome that?
See, most of time when they are going for the surgery, sometimes as I have told you, when they are making conjunctival flap, they are holding the conjunctiva near at the limbus, where your conjunctiva, your tenons capsule and your sclera, they are tightly fused. And if they try to introduce your this forceps Caesar, then they go partially in the sclera. So at the step of this conjunctival flap, they are doing this mistake. At the level of tunnel formation, when they are giving their incision, their depth is not proper. They are either they are making a very deep one or they are making very shallow one. Or sometimes their shape is also, when they are trying to make a straight incision, it is actually a smiling type incision, and their size is also not there, and they are giving multiple cuts. So it is not required you give a multiple cut. You first propose your outer lip and then make a single cut with appropriate depth. So the second challenge is there. Okay, and third chapter, when third one is when they are entering in the AC. At that time, they are not actually inflated the chamber. They are enter their keratome with the loose chamber. So that time actually it is not cutting, but it is lacerating the wound. And when it is laceration, the tunnel is not stable. Then at the level of hydro, they are just pushing in the center. They are not go inside the rexis. So first you go inside nearly 1 to 2 mm towards below the rexis and facing towards the periphery. So they are not moving up to that level and they are pushing the saline. So the half saline is going towards the outside. And before it, they are not washing the visco. So there is resistance present in the anterior chamber. So it is important that first you empty the anterior chamber with visco. So only fluid is there and there is no resistance is there. So at this level, they performing this type of mistake. When they are making side coat, definitely their side coat size is smaller, right? And when they use this small side coat, they lacerate the wound. So most of problem is laceration of wound, and most of students making this capsulorhexis with the side coat, right? In my opinion, actually, in side coat you have lesser space, but if you are using more main tunnel, that time actually you have more space, so you are move your hands more than the side coat. But disadvantage of this technique is that because in if you are using main tunnel, that time actually what happens, you need a visco, frequent visco and full chamber visco. So most of students prefer to make a side port with the help of your side port, right? So my opinion is you inflate the chamber and may use the main tunnel and not pressing the tunnel. If you are pressing the lower lip, that means you need again and again to fill the AC with the visco. Okay, so this thing, and when they are removing the nucleus, they are not actually engaging the nucleus. Before they are engaging the nucleus, if they are pushing the hydro, that means the loose structure, that is iris, they are coming and stuck in the your wound. And when you are pulling, you do the this iododialysis or damage to the iris. So these are actually some important steps which are required. And in last, when they are closing the wound, that time actually their tunnel, this tip of your needle is not facing towards the corners of these, and they are facing towards the cornea. So it is not actually hydrating, but you convert your cornea into cloudy cornea. Okay, so these are some important steps. I think they uh, careful for these steps.
Thank you so much. Those were very useful tips for the beginners. And the other question I would like to ask you, you mentioned a lot of techniques for the delivery of the nucleus. What is your preferred technique that you use in your?
My preferred technique is irrigating wire practice, because here actually you have a hydro and you save the both surface endothelium and PC with the hydropressure. And if you have sufficiently engaged your nucleus, that time actually only fluid is present inside, and this preventing your both surfaces. In another technique, you may sometimes rubbing over the cornea, you taking a support of the cornea. So my preferred technique is hydroprolapse.
Thank you so much. Yeah, I think it's very important to protect the cornea because a lot of
Yes.
beginners make that mistake and then land up with a hazy cornea on the first post-op day.
Yes.
So,
Most of time actually they are supporting the cornea. This is actually not required. You just not support, but you hold the nucleus on the wire vectis and then pulling it by pressing the lower lip. So you are not rub over the cornea, right? It is very important actually.
and what is your choice of a capsular opening that you do out of all the envelope or the rexus or the can
Yes,
opener?
I am doing capsular access because it is the most advanced one and it is the most too much advantages of these rexes. So I am using capsular access and it is not very difficult. But important thing is that your axis size should be sufficient. Because in phaco you are phacoemulsify all nucleus inside the capsule, but in SICS you are prolapsing the nucleus. That means its size should be bigger than the uh, nucleus one. Okay, and if you feel any type of problem with small axis, then you go relaxing cut or you increase the size of your axis. Without sufficient size, you not
How many relaxing
successful.
cuts? How many relaxing cuts are
You
recommended?
give multiple and small relaxing cuts, because if you give one big cut, there may be more chances to the radiating tear. Okay, so you give multiple but small cuts. Okay, otherwise you go give a cut and resize your rexis, right?
Okay. Thank you so much. Very, very pertinent points that you expounded on. And thank you again for this very wonderful talk. With that, we move on to our next speaker, Dr. Arundhati Pandey. Dr. Arundhati is presently the head of the department and professor at the Symbiosis Medical College for Women at Pune. A keen academician, she has been presenting extensively at various national and international fora. Apart from that, she's also an excellent innovator and has a Government of India approved patent to her credit. Another facet to her persona is the fact that she is an avid marathoner, a triathlete, a cyclist, a trekker, and has also completed 5 half Ironman competitions. So, Dr. Arundhati Pandey, we look forward to hearing you on the complications of cataract surgery. Over to you.
Yeah. Can you? Good afternoon. Good morning, everyone. Thank you so much, ma'am, for a very nice introduction. Can you hear me?
Yes, we can hear you. We can see your slides. You can make them free.
Okay. And thank you so much, AIOS, Dr. Santosh Honawar, for giving me this opportunity. I'm really grateful. And thank you, sir. It was a very good presentation of your SICS, and I got very, I learned many things. So thank you so much. So I'll be talking about cataract surgery complications. See, I would love to talk about questions arises. After any complication, you have so many questions. Then surgeon related few points, patient related, and main complications. So if any complication happens during any kind of surgery, especially cataract surgery, then you think, oh my God, why this happened? How it happened? Now what I should do? Okay, and do I need more training of this? So I was a panic mode, or I had anxiety, or what went wrong in the surgery? Coming to the main important issue, I would like to discuss about this thing because we talk about surgery, surgical complications, what happened, but no one talks about the surgeon itself. Okay, so I would like to highlight this point. So surgeon related physical health. How is the surgeon's physical health? Is he suffering from any diseases or any did he have any exercise today morning? How was the food? Okay, and all these lectures are meant for PG students. So I would love to discuss about the physical health of the PG students, because already you are staying in the hostel, the food quality is not good, eating samosa in the morning and doing the surgery again, it's a difficult job for the surgeon's physical health. So a good health is very important for any surgery. Then how is your mental health? Mental health again is very required. Did you have a good sleep? Did and during residency, because of a workload and the heavy workload, you don't get enough sleep. Your personal and the personal life and the professional life is it's everything is mixed, and you go through many ups and downs during residency. Then coming in the OT, if the PG student is coming in the OT, how is his position? Sitting on the chair, how is his position? How is his posture? Position of neck, then his back posture. Is he comfortable or not? If PG student is doing the surgery, how many surgeries has been done, or what is the exposure, and what is the mental status of the student? Generally, whenever if you're doing in the initial phase of the life during residency, many times people, they suffer from the headache due to strain. There is a you don't know the IPD adjustments, or you come up easy. It takes time to get adapted with the hand-eye coordination. So IPD adjustment is must. Then numbness, any position, if difficult position, or see, I'm a 5 feet per surgeon. So I'm doing the surgeries at various hospitals. So whenever you're doing the surgeries, then I have to adjust the chair height, table height, the patient head height, and everything. And if there is a problem, then numbness, feet numbness is very common. Stress, anxiety before the surgery, and mood fluctuations with your seniors, because at the home front again you have many things at home, and you're doing the work also, you're studying also. Patient related, so pre-op morbidities like BP and sugar, they're the main culprits during the surgery, and we need to take at least we have to take medicine fitness or anesthetic fitness for these situations. We have to control the BP and sugar. I was operating on a squint patient, and so we ask, okay, for local anesthesia, we ask have a light breakfast. So this I asked him, okay, did you have any breakfast? He said, yeah, I had. So after giving the local anesthesia, he said, no, I feel vomiting. He vomited once. I was like, okay. I called anesthetist. Now she said, okay, let us give him an antiemetic. She gave her antiemetic. I started my surgery, and during conjunctiva, after doing the surgery, during conjunctiva closure, again he said, no, again I'm having a vomiting sensation. Then again he vomited out. After the surgery, I asked him what you had, and he told me the surgery started at 10 o'clock in the morning, and he had at 8 o'clock in the morning a good breakfast of a chicken. Okay, and I started like, okay, so this can happen. So in the history, again, you have to check what is he had or the patient had. Psychiatric or uncooperative patient, again difficult to handle. Anxious patient, they will talk very nicely with you during pre-op, during their OPD visits and during investigation visits, but the moment you put on the table, you will see the increase in the blood pressure, but after talking to them, their BP will come down automatically. So what I'm covering: complications, preoperatively, intraoperatively, early postoperatively, and late postoperatively. This is for the theory purpose. I would like to take you on my experiences of the journey, because again it is very important. So I'll be discussing with you all tunnel related, capsulotomy related, hydro related, iris related, lens related, and IOL related, and posterior capsule wound related. Now coming to preoperative complications. So anesthesia related, everyone knows, though we operate in a local anesthesia, but still there are chances of local anesthesia complications. So cardiac arrest is a very common, not very common, sorry, but the cardiac arrest happens due to parasympathetic activation during cataract surgery. So we have to monitor patient's BP, pulse, and how is he feeling. So we had, I would like to share one experience. I was operating for a cataract surgery. After giving a local block, he was telling us that I'm not comfortable breathing. Okay, so we changed the AC temperature. We did. I mean, the patient was drept, so we removed drept and asked him to breathe, but still he was not comfortable. So I called anesthetist, and anesthetist said, okay. He checked his pulse BP. He had BP of 150/80, but to be on the safer side, because we are having the hospital, so we took the patient's ECG, and it was a myocardial infarction. So immediately we shifted patient to ICU. The management was very good in ICU, and after a couple of weeks, again patient came back to us for cataract surgery, and I did the cataract surgery. So still, after after getting the fitness from the anesthesia, I check ECG personally. So this is the learning happen. So I would like to discuss intraoperative complications in detail. That this is the main thing. Okay, so bridal suture. Yeah, we know that whenever we are taking a superrectus suture, so that is called as a bridal suture. So superrectus avulsion, though it is rare, but I would like to mention about this. And sometimes the needle causes a globe perforation. So you will come up across hypotony. There will be a vitreous under conjunctiva and a vitreous hemorrhage. So immediately we have to shift patient under a vitreoretinal care, and to avoid this, simple use round body needle. This prevents all the complications. So tunnel related SICS, there will be always a good play of the deep incision, which will cause a premature entry and buttonhole. So after finishing my SICS training, I joined the hospital. So during SI training, I did not have any tunnel related complications. And on the first day, I had premature entry. I said, okay, let us handle this. So I should not go in deep. So next day I went and I went very superficially. Again, next day it was a buttonhole. Third day, I said, okay, I was very superficial. So let me go slightly deeper. It was again on the day 3, again it was a premature entry. So I was literally struggling for the couple of days for that premature entry and buttonholing. Then what I understood is I should start my tunnel either side of the right side or the left side rather than starting in the front. I mean, at 12 o'clock. Okay, and now after doing the SI, see, every surgery has its learning curve, and every surgery has it gives you the many learnings. Now phaco related, yeah. So phaco tunnel related. So phaco related, theoretically there are many complications, but flap cutting is a very common complication which I come across, and even my PGs, they do have this flap related complications, either cutting of the flap or through and through cutting of the flap. So we have to shift to we have to make another tunnel. That is the solution for it. Anterior entry of a phaco tunnel. Okay, if I'm going, immediately for the entry, again the early entry, or I'm going horizontally into the cornea in the corneal stroma and then entering into in the anterior chamber. Again, that is a problem. And long back, we had one surgeon, and he had a through and through entry. Like he started at 12 o'clock. The phaco tip started he entered into at 12 o'clock, and then the tip went till 3 o'clock. So we have to suture at 6 o'clock. Sorry, he went at 6 o'clock. So we have to suture at 6 o'clock. Again, do another tunnel, and do the cataract surgery. Side port related. See, after the flap, side port, if there is a blunt side port, okay, generally this you will come across with a descemet membrane detachment, because if your entry is again wrong, or if if you're entering either periphery or in the center, then descemet membrane detachment, you have to put a air bubble immediately, wait for some time, okay. And post operatively also, we have to monitor this patient, whether, for a corneal edema. Then hyphema is a very common complication during the surgery, either side port related or cannula related, or sometimes trauma. Once I was just injecting visco, okay, and the visco cannula was loose, and it went inside, and it caused a iris hole, and bleeding started. And that bleeding was so severe that I had to wait 10 to 15 minutes. I had to control that bleeding and then start the procedure. And hyphema, if it is mild hyphema post-operatively, we control with steroids and antibiotic combinations. But if it is a full chamber hyphema, yeah, we have to take the patient to the OT and give a anterior chamber wash. Capsulotomy related. See, as I explained, the can opener, envelope, and continuous curvilinear capsulorhexis. So yeah, CCC has more learning curve, but it is so that is why we ask our PG student to do the practice on the boiled potato or a tomato to make the CCCs with the help of a cystotome. So in the initial phases, either there will be a small CCC or a big CCC, or incomplete CCC, or the flap is going in the periphery, then irregular CCC. And if we don't, if the surgeon doesn't understand, then it may extend beyond equator, or so it will cause a PCR, extension of the PCR, extend PCR. Hydro related. So hydro should be slow and gentle. So incomplete hydro will cause the complications, because if the nucleus will not rotate properly, and if there is a nucleus rotation is incomplete, then your phaco and the small is again difficult. Important point I would like to tell this is posterior polar. In posterior polar cataract, hydrodissection is to be avoided. It is, you never do hydrodissection, and slow rotation of nucleus is mandatory in the routine cataract surgeries. Iris related. Iris prolapse due to premature entry. It's a very, if you have a premature entry and you understand, okay, this is a premature entry, then your iris comes, okay. The iridodyne, sometimes it causes like iris prolapse. Then at the at the time of a nucleus delivery during small incision, iridodialysis, it happens. Sometimes if you put the during phaco, if I'm doing phaco, but if iris is coming, okay, so sometimes what happens is then hyphema comes, okay, iridodialysis happens, even especially during small incision, then PCR followed by vitreous loss. So all the consequences, they do happen. What should we do? So keep calm, that is the important thing. And whenever there is iris prolapse, just first try to reposit it, put a visco, and do your further procedure, either phaco or small. And if it is troubling a lot, if it's coming again and again, just do all the procedure keeping you calm. But nucleus delivery you should be very gentle while doing the nucleus delivery, because iridodialysis happens. Very commonly this happens. So we have to do iris suturing, that is a MAC canal suturing with a 10-0 proline. And if there is an irregular pupil, we have to do pupilloplasty by 4th row suture. Again, a bigger problem is a small pupil, because small pupil with a cataract, it's a different combination. We need a good learning curve to handle this. So generally I use iris hooks. I'm very comfortable using iris hooks. I put 4 iris hooks. My tunnel is temporal, and then 2 side ports. So very convenient. But yeah, We can use a BHEX pupil expander also. It is slightly tricky to insert and while removing, but once you are comfortable with BHEX, you can proceed with BHEX pupil expander. And the other option is iris hooks. So what are the nucleus related complications? Zonular dehiscence, if you're doing small incision cataract surgery with a small CCC and you're maneuvering your nucleus, generally this is the time where zonular dehiscence happens, okay, or subluxation of nucleus. Then if you handle it very if you are not gentle with all the steps, then this complication they do happen, because PCR is a very commonly seen vitreous loss, nucleus drop. Nucleus drop is if you don't understand PCR, okay. See, for example, if the posterior cataract is there, if you do hydrodissection, the PCR will be there. PCR is there, and if you do it very forcibly, the nucleus will drop immediately. So what are the things to be done for zonular dehiscence management? For zonular dehiscence management, I generally put CTR, and CTR is put. It can be put through side port or through the main tunnel, also through the phaco tunnel or a small incision tunnel. I prefer to put the CTR after cortex removal, but some people you can do it before nucleus delivery also, before cortex aspiration also. And the Sioni ring again is of a benefit because it has two extra eyelets, and that is a bigger and more better advantage. Cortex removal. Okay, so everyone knows that the cortex removal is a very easy step, but during cortex removal, chances of PC are very high, especially the last chunk of the cortex aspiration, and you have a PCR. It's very common. Then I come across with, we are having a PG, so we during cortex the anterior chamber is shallow, then corneal edema is very common. So few points about a posterior capsular rupture. It happens intraoperatively if in the patients of a glaucoma, or if there is a small pupil. Okay, the incidence of the PCR is 0.2 to 14%. Okay, because cataract surgery, it has its own learning curve, and because of this learning curve, initially you will have many complications, but gradually as you learn the procedure properly, all the complication all the complication they goes down. So yeah, in spite of the PCR, put IOL. Early post-operatively, wound leak is it's a very common complication. So if on the table after doing the surgery, if you feel no, the eyeball is very soft, my advice is please take a suture. Okay, there is no harm, no ego issues while taking the suture. But next day again taking the patient to the OT, it's again psychologically traumatic to the patient, because he will think, oh my god, what is happening with my eye. So, and wound leak, how you diagnose is a put a fluorescein, there you will see a gush of aqueous is flowing through the wound. Then stride keratopathy, yeah, central touch is very common in phaco, but it goes off with the medication. Corneal edema, depending upon the level, how much, what is the corneal endothelial count of the patient, and how is the surgeon's maneuvering steps of the maneuvering cataract surgery. Then shallow AC, yeah, because of the either wound leak or because of a choroidal detachment. Then hyphema I explained. IOL displacement, yeah, sunrise and sunset syndrome. If the IOL is going up, then it is called as sunrise syndrome, and if it is coming down, it is a sunset syndrome. Generally, it happens because of the zonular dehiscence or zonular dialysis, and if you did not put any CTR ring, choroidal detachment, hyphema, and endophthalmitis. So this is a picture of a choroidal detachment, B scan. It's a typical of choroidal detachment. Iris prolapse, yeah, post-op day 1, or sometimes the patient come up after 8 days that, oh, I had this trauma or something has happened at home, then he may have iris prolapse. So take the patient inside the OT, and you have to suture the wound properly with a 10-0 ethylone. Late postoperative complications, so pseudophakic bullous keratopathy. Yeah, the corneal people, they do have an eye on these cases, and they do a good work actually. So it is better to have a good corneal support for you, because after doing cataract surgery, and if the patient is having a low endothelial count, okay, they may land up with a pseudophakic bullous keratopathy. And various techniques are available with the corneal people, so it is good to refer a patient for a pseudophakic bullous keratopathy rather than giving him a trial of medicines. Okay, generally I wait for 1 to 1.5 months or 1 to 2 months max, and then I shift the patient for the cornea to do keratoplasties, lamellar keratoplasties. Then IOL decentration, iris shafting. Iris shafting is when you are learning PECO. In the initial cases or in the initial phase of a PECO, this happens, but don't worry. I mean, it will not cause any problem. Only patient cosmetically will ask you, oh, what is that white dot is seen in my eye? So you have to explain everything. Pupillary capture, fibrous ingrowth, epithelial ingrowth, glaucoma, to name a few. Okay, now endophthalmitis. Endophthalmitis is a very vast subject. I mean, it's a topic for a discussion, but I would like to mention because this is a surgeon's nightmare. So if you are suspecting endophthalmitis, please take the vision. Okay, day of surgery is very important because generally the initial phase, the first 24 hours, and if there is a reaction in the anterior chamber, so doing a B scan, it will we will exclude the task. I mean, if I see in the B scan, if I see the reaction, if I see movements in the vitreous cavity, then obviously it is an endophthalmitis and not a task. But if vitreous is clear and the patient is coming within 24 hours with a AC reaction, streak of hypema, it is a toxic anterior shock syndrome. And TAS, we can cover it with the steroids and the atropine, but yeah, endophthalmitis, we have to take a help of a vitreoretinal surgeon and giving intravitreals, doing and the prognosis according to the scales and the guidelines. Patients are we can manage patient very nicely of endophthalmitis. Endophthalmitis incidence is 0.04 to 0.4%. So in a span, in the surgeon's span of 20 to 30 years, 20 to 40 years, I'll say, you will come across with endophthalmitis, but you should not get worried or you should not become panic. Posterior capsular opacity, it's very common with hydrophilic AIOS, and but very easy to remove it with the ND, yeah, capsulotomy. Post-operative complications, early post-operatively, yeah, as I mentioned, striate keratopathy, corneal edema, shallow AC, choroidal detachment. Late post-operatively, they are pseudophakic bullous keratopathy, PCO, IOL decentration, fibrous ingrowth. This is for a PG's writing purpose or for long question. I would like to discuss one case of mine, which I operated few years back. So 62-year-old gentleman, he came to my OPD saying that, okay, I'm having a cataract, and I took his detailed history. So you name the disease and he had it. So diabetes, BP, IHD, then thromboembolic phenomenon, diabetic foot, and he had a grade 3 cataract. So he said, no, I have to go. And he, because he was taking so many medicines, he was knowing many things. Okay. And he was on steroids for 5 milligrams since last 25 years because of autoimmune disorders. So he asked me, he took my viva actually. He asked me from where you did your graduation, post-graduation, how many surgeries, how many complications, and how did you manage and everything. Because I feel that because he had so many problems, so it is it's okay to discuss everything with the patient. Now he was on the clopidogrel. So yeah, technically we have to stop clopidogrel on the day 5 and for 5 days, and then we can do the surgery. So he was knowing everything. Then I under local anesthesia I generally do topical anesthesia, but because he was high risk, so I started under local anesthesia. Under local anesthesia, I I tried to take the flap. I mean, for the phaco, and the first step and the flap, there was a cutting of the flap. I said okay. So I took the another flap. I mean, I entered through another tunnel. I made the side port, and I started my CCC. And he had a bout of cough. My CCC went periphery. I said okay. So I tried to convert it. No, it was no scope. So a small 2 o'clock, I had to do a can opener. I said okay. Doing during phaco direct shock, no, the nucleus was not ready to break. So I did stop and chop technique, and the last piece was coming. I was doing the phaco of the last piece. There was the sudden, all of a sudden that PC came. There was a central PCR. Luckily, I had a coat. I mean, good viscoelastics. So visco coat actually I had. So I put visco. I did the vitrectomy. I had to remove a cortex. After putting IOL, I was about to close that case. After putting the IOL, the iris started bleeding. Okay, it was a very fresh bleed. After wash, generally it goes off, right? But after the washing, it was again coming. So it was 15 to 20 minutes of play of a bleeding episode. And I put a tamponade, air bubble tamponade. No, still it was oozing and oozing and oozing. So I was like, I was helpless. And then I thought, okay, be calm. So I waited till I said, okay, let the bleed come. So we'll do something for that. So after this, I waited for 15 minutes. I removed the clots and the blood. Okay. And because of the waiting period, it stopped. After doing this, that flap was there, right? So I started suturing. The moment I put my limbs, okay, this epithelium came out like a paper. There are multiple patches of the epithelium. It came out. Okay. It was first time for me to see this kind of epithelium is coming out, a paper thin epithelium. And unfortunately, my instrument limbs, the tooth was not there. So I tried to get the another limbs and suture the wound. But in the anterior chamber, obviously there was a streak of hyphema was there. And patient asked me, okay, madam, you told me that it will be a 20-minute surgery. But what happened? I say, okay. So after finishing the surgery, I explained everything in detail to the patient and the patient relatives. Okay, that okay, the bleeding happened. Then he told me, okay, madam, see, I was supposed to stop the clopidogrel for 5 days. So today is my 5th day. Okay, so what I learned lesson is, okay, stop the 5th. I mean, because it was a Friday and his son wanted, like Saturday, Sunday, he wanted to be with his father because he came out from Mumbai. They decided, okay, we'll do on Friday, the 5th day of the clopidogrel. So lesson learned is stop clopidogrel for complete 5 days and then take the patient. On the day 1, the patient had 624 vision, but because I explained everything in detail and we had many discussions before the surgery, patient said, oh, I can see it very clearly, so I'm very comfortable. And eventually within 4 weeks his vision increased to 6-9 parts, and he was very happy. Okay. Fortunately he came for the second eye also, but we took all the care, and I checked instruments, okay, beforehand. So, and other eye he had 6-6 vision. So and one more thing, so after doing the surgery, throughout the day I was very stressed. Okay, so next day even I had a very not comfortable sleep. Next day morning I said, what should I do? So I was supposed to do a 30-kilometer cycling, okay, that day. So I said, okay, let me go for a cycling. During the cycling, I did my critical thinking that what happened. Okay, I went through the whole surgical procedure again. I realized, okay, whatever I can do, I have done best for that done for the patient. So I have nothing to worry. But yeah, let us see how it goes, because we have to respect tissue, we have to respect patient. So the way to get started is to quit talking and begin doing. Okay, by Walt Disney. So take home message is whatever is happening, it's absolutely fine, but you should think critically, like why, how, and what to do. Okay, learn from seniors, discuss with your seniors and colleagues and friends. Communication with patient in detail, it helps a lot, a lot. And how to overcome, because 1 or 2 days again you have your own set of issues after the surgical complications, but you have to overcome, you have to face the patient, you have to face the life. And see, I would like to tell you, everyone is having their own issues. So in the background, everyone is suffering. Okay, so be kind. You don't know the background music of the person's life. So be kind with the patient also, and be kind with everyone who you are come across, because they are having their own struggle, but because we are kind, they will feel calm with us. Believe in yourself, always believe in yourself, and whatever happening is happens for the best. Be patient. Read and discuss, keep updated with the new technologies, and the conferences are happening. So I mean, updating yourself is the important thing. So thank you so much, everyone, for listening. This, let me give me feedback. I'll be very happy. And I'm there on the LinkedIn, Insta, Facebook at Dr. Arundhati Pandey. And my mail ID is drarundhati@gmail.com. So thank you so much.
Thank you, Dr. Arundhati, for walking us through the complications of cataract surgery and for sprinkling your talk with these nuggets from your personal experiences, which made it all the more interesting. And some things that you highlighted was, of course, being kind to the patient, being empathetic. And of course, it's they say that forewarned is forearmed. So it's important to update yourself, be aware of all the complications that can occur, be prepared to handle them whenever they do. You know, you should be having an outline in your mind that if this complication occurs, what is to be done. And of course, confidence and mental strength is very important for a surgeon. That is also what you highlighted very well. So thank you so much.
Thank you. Thank you.
Thank you. So I'll just ask you a few quick questions that we have. You mentioned briefly about subluxated lenses and you using CTRs or Sione's ring. So what are the cases where you would like to use a CTR and where would you like to use a Sione's? And, so if you could expound on that.
Yeah, so generally I use CTR. Okay, the moment I generally during pre-op examination, if the patient is having subluxation, yeah, we keep it ready. Okay, subluxation, then Marfan syndrome, again children with a cataract. Okay, and especially glaucoma flaken patient, because anything happened during those surgeries, and small pupil is again a tricky situation. And Sione's ring, yeah, I never use that.
Okay. And also, could you give us some pointers as to how to manage the intraoperative floppy iris, which is again a bugbear of surgeons. Once it occurs, everything starts going downhill. So just a few quick pointers on how to manage that.
Yeah, so history is very important. If the patient if the patient is having a benign prostate hypertrophy, is he taking any medications? Okay, if the patient is taking the medication, then yeah, you will end up with this thing, floppy iris. And recently, Dr. Susan Jacob, she has mentioned about the endodiathermy, and I tried that, and it's a very good technique. So with the cautery, actually, we have a phaco machine cautery. So with that cautery, you just apply in the mid stroma, just apply few, what do you say, few, apply, few spots apply, then it will not trouble you much. Okay, and it helps me a lot for floppy iris. And first thing, and second thing is, if there is a floppy iris, we have to handle it. And if there is I do dialysis, then I suture it with the 10-0-proline.
Would you like to use some pupillary expansion devices in all these cases?
BHEX. I use BHEX, ma'am.
Right in the beginning of the surgery, if you anticipate.
Yeah.
Okay. Also, 3 quick tips on how to recognize a PCR when it occurs. What are the signs that make you suspect a PCR has happened?
Sudden dilatation of the pupil, first thing. And if you're doing a phaco, if the last piece or while doing the cortex aspiration, you should be very gentle, because the moment you touch it, you will see there is a hole. I mean, for the PGs, it is slightly difficult to manage it, or to see the hole. Okay, but after having that, how many 20 years experience now, I can see the hole. But the sudden pupillary dilatation, there will be sometimes there is a gush of the vitreous also. Okay, and you'll see the hole. So immediately you stop your phaco. Don't remove the handle, phaco tip or a cannula. You just be calm, put a viscoat, and then you remove the instrument. That is the tip.
Thank you so much. Thank you for those very useful tips, and thank you for your talk. And so there are no more questions. We'll move on to the next talk.
Okay.
So our next speaker is Dr. Sushmita Kaushik, who is a professor at the Advanced Eye Center at PGI Chandigarh, where she has been a faculty since 2004. Dr. Kaushik specializes in glaucoma with a special interest in childhood glaucoma, newer diagnostic tools, and glaucoma surgery. She has more than 170 publications to her credit and has also authored more than 40 chapters in various textbooks. She is also the founder secretary of the Indian Pediatric Glaucoma Society and former secretary of the Glaucoma Society of India. A winner of various accolades and prizes, both in India and abroad, she is truly an authority in her field, and we look forward to hearing her speak on her subject of choice, imaging in glaucoma, know what to order. So I welcome you, Dr. Sushmita, and invite you to present your talk.
Thank you very much. Good morning. Let me share my slides. Is it visible? Are the slides?
Yes, they're visible.
Right. So at the outset,
you could make them full screen. They're not full
is
screen.
that all right? Is that
yeah, it is all right, but we can just see half the. Yeah, okay. You just carry on. Maybe we come.
Okay, it's full screen on my system. So
okay.
It's full screen. It's full screen, doctor.
It's full screen. Yes, please carry.
Thanks. So at the outset, thank you very much, Dr. Santosh and AIOS for this wonderful online Guru class, and we hope that it's going to be of help to people, and I'm very happy to be able to present a little bit of our work and a little bit of what we do. So nowadays, with AI coming in and everything else coming in, everybody seems to think that clinical ophthalmology is all going to be done by machines. And if I might just say that that's not going to be true, because clinical ophthalmology, at the end of the day, clinical examination is going to hold the key. And I hope, even though this talk is about imaging, and I hope when we go through it in the next couple of minutes, we'll see why that's true. So to split it down to glaucoma for a postgraduate, angles have a problem, and that's the cause of the raised pressures. And the optic nerve is the effect of the raised pressure. So the trabecular meshwork is the problem, and the effect of that problem, that is damming the aqueous inside the eye, raising the IOP, is what is going to cause a deterioration of the optic nerve head and the ganglion cells in the eye. So interestingly, all we have to do in imaging in glaucoma is image the angle for abnormalities and image the optic nerve head. So why is it helpful? Of course, this is Professor Weinreb's important diagram, which told us that glaucoma is a continuum rather than a one-stage disease, and where you're going to catch them is where you're going to keep them if your therapy is successful. So obviously, if you catch them somewhere here, it's more likely that you're going to preserve their visual function than if you're going to catch them somewhere right around the red spectrum, where you're not going to be able to do much. And the problem is early changes may be very difficult to detect clinically, and preclinical glaucoma may be not detected, and you can probably pick them up objectively. Also, the pathophysiology of angle closure can be delineated very well if you image the angles. So what do we need to image? To image the optic nerve head and nerve fiber layer, remember the HRT is for the optic nerve head, and the OCT, which is so popular these days, is actually imaging the retinal nerve fiber layer and not the optic disc, as it were. And the angle, of course, you have the ultrasound biomicroscopy. So that is a high frequency ultrasound, normally 50 megahertz, to look at abnormalities in the angle and ciliary body. And now with the CASIA or the swept source OCT coming in, the anterior chamber OCT is also becoming a tool to evaluate certain structures and certain functions of the angle. So in the outline in this talk, we'll talk of imaging tools in glaucoma, the nerve fiber layer, which is the most common by the OCT RNFL, but also the ganglion cell measurement, the GCA, and why that's important. Most of my work has been done on the Cirrus OCT by Zeiss, no financial disclosures, but it's the machine we have the most access to. The optic disc with the HRT, there are certain situations where it's important, though it's not a very widely available machine. But if you really want to do structural evaluation in certain conditions, I would suggest you refer to a center which has an HRT, which is going to be very, very useful for follow-up. And for the angle and anterior segment, we'll look at the UBM and the ASOCT. But more importantly, we'll try and understand the funda of the OCT in glaucoma, which is important because it's not true that red equals disease and green equals normal. And I hope by some real world situations, you'll understand why that is. So the main uses are detection of abnormality and an objective follow-up. So I did talk about the HRT, so we'll do a quick thing of what this is all about, the Heidelberg retinal tomogram. It is actually a confocal laser ophthalmoscopy. So CSLO is the technology, and the proprietary name is Heidelberg because it came from Heidelberg Industries in Germany. So this is a two-dimensional section is made at the focal plane, and then you have many slices of that. And when the focal plane is moved back, there's a series of optical sections at different depths and forms a layer by layer three-dimensional image which looks 3D when you look at it. So this is typically glaucoma on the HRT. You can see this thinning here. You can see a corresponding superior visual field defect. And on the HRT, all these structures, these segments of the optic nerve head are flagged green, whereas this bit is flagged red. So this is what is going to tell you that probably this disc over here is glaucomatous. But remember, with the HRT, it's a disc-based tool. So it looks at the cup to disc ratio more importantly. And therefore, in larger discs, since the cup to disc ratio is more, these larger discs may be flagged glaucoma by the HRT. So that's something to keep in mind when you're thinking of imaging with the HRT. So this is what the OCT report looks like. This is a typical glaucoma patient. You can see an inferior rim thinning, an inferior RNFL defect, and you have the superior visual field defect. So this is clinical. You don't need an OCT to tell you that this is glaucoma at all, but an OCT would be useful to document that. And you can see the inferior RNFL is blue. So the hotter colors are thicker and the cooler colors are thin. So that's the first thing to figure out. And then, so this is known as the RNFL thickness map, which is color coded according to thickness. The next is the RNFL deviation map, which means how much is it abnormal in comparison to a normative database. So this is like your visual fields. The ones which are very abnormal with a significance of less than 1% are flagged red. The other ones are yellow. And if there is no difference with the normal, it'll remain gray. So these gray areas are normal RNFL, whereas this bits here, the red are actually, it means that it is significantly thinner as compared to a normative database. So this is a deviation map, deviation from normal. And the first ones are the thickness map, which only gives you an idea that these parts of the retinal nerve fiber layer are thin. And similarly, you have these flags depending on significance. So it's all statistic. This is significance. These are quadrantic hours and these are clock hours, which tell you that this bit of this OCT report is likely abnormal. Why I'm saying likely is because this is compared to a normative database. And remember, 1% of these normals had thickness which is falling into this. So the probability of normality is less than 1%. That's what red means. But in this normative database, remember the OCT has no glaucoma database. In this normative database, 1% of those normals still had a thickness which was this much, right? So that's important to understand that this 73 and 53 microns are normal for some people. For all you know, they might be myopic. They might be they just have a thin RNFL layer, but they're normal. So that's something to keep in mind, that it's all statistics. So this is the fundamental, and I like this slide very much because it also tells us pathophysiology of glaucoma. So what happens is you have a thinning at the lamina cribrosa, or you have a pressure dependent problem at the lamina. The axons are pressed, and what happens? The ganglion cells are damaged. So you have a ganglion cell which is damaged here, which is shown on the GCC. What happens next? Once these ganglion cells are damaged, its axonal transport is a problem. So you can see the RNFL, which is the axons, which become thinner. And this is what translates these ganglion cells, which are defective, translates into these superior field defects, because this area of the retina does not perceive light, and therefore it comes up as a scotoma. So this is a fundamental really of what the OCT is doing to us. Why do you need a ganglion cell analysis? Remember, the loss of RGCs in the inner retina is what constitutes glaucoma. 50% of retinal ganglion cells are there in the central 4.5 millimeters, and the peak ganglion cell density is there at the macula. So it makes a little bit of sense to image ganglion cells at the macula, and possibly when it came in, it was touted as being even pre than an RNFL. But then as we've learned and as we've understood the technology, that's not always true. But the other advantage is that it's less influenced by, say, peripapillary atrophy or high myopia or something around the disc. So you have another surrogate measure, which is the GCA or ganglion cell, to tell you whether there is glaucoma or whether it is progressing. So on the serous OCT, remember, you have a GCA, which means a ganglion cell analysis. The difference between a GCC, which is what you see on the OptiView, is that the OptiView's GCC includes retinal nerve fiber layer, whereas in the serous, the retinal nerve fiber layer is taken off from the segmentation. The segmentation is only the retinal ganglion cells and inner plexiform layer. So that's a small difference to keep in mind, which also tells you that you can't compare a GCA of a serous to a GCC of the OptiView or anything else, simply because not just that the normative databases are different, but also the segmentation differs. So it's important, if you're doing follow-up, to stick to one machine and not across machines. So this is what a normal patient would look like. We've gone through this. So this is a normal, largish disc, a largish cup. We see a lot of these in the glaucoma clinic who are referred to us with a 0.7 cup, but with healthy rims, large disc. You can see the fields are near normal. This is a normal RNFL and this is a normal GCA, which means that these are nice and robust. You can see they are nice and yellow. So if you see lots of yellow and red on an OCT report for glaucoma, that's good. If you see blues, they are bad, which means they are thinner. So here there are no blues and nothing, and everything is fine. Then moving on, this is early glaucoma. So I'm showing you clinical. So this is how it should go. You look at the patient, you diagnose the glaucoma, and then you ask for imaging, just one, to corroborate, but more importantly to get a baseline so that you can follow up. I don't think you require imaging to diagnose glaucoma at all. So this is, again, you can see the thinning over here. This is a notch. You can see the visual field defect in the right eye. The left is normal. And in early glaucoma, you can see this is an inferior RNFL defect, right? And then there's no question at all that there is glaucoma. But now you have the GCA. And the GCA, even though it shows up a little bit here, is all green. Now, why do you think the GCA is normal? So if there is glaucoma, this GCA should have shown up as some red, isn't it? But it's all green. So remember that this GCA does have a little bit of an ganglion cell loss here, but it's not coming onto the quadrant, which is all right. But the GCA, the RNFL on the other side, of course, shows this up. So this is glaucoma, all right, even though quadrantically the GCA is normal. So that's what I meant, that green is not always normal. Whereas in advanced glaucoma, it's not so important. Remember, there is something called a floor effect. Even in an OPL glaucoma, there will be structure, there will be Mueller cells, there will be axonal elements. So there will be some thickness, and that thickness has been shown by Dr. Ramanjit's group to be about 40 microns. Below that, your glaucoma can continue to progress, but your RNFL and OCT is not going to show up anything. So in advanced glaucomas, it's the visual field or functional status which is important for you to follow up patients for progression. Whereas in early glaucomas, the visual fields may not show up as quickly as an OCT might. So the OCT is a tool for following up patients with early glaucomas, whereas the visual fields is a tool to follow up patients with advanced glaucomas. I'm going to give you one pearl to understand the OCT, and I want you to take this in your head whenever you're going to read a report on the OCT. The topography of the structural defects affects your OCT measurements, which means where the defect is affects the measurement on the OCT, and we'll see how. Now, this is a straightforward POEG, right? When you're going to look at this, there's no question at all. You should be able to see this RNFL defect even on the color picture, but also definitely on the red free. And here you are similarly, so a superotemporal RNFL defect with an inferotemporal field loss. There is no question at all that this is, so what is glaucoma? It is a glaucomatous optic neuropathy with corresponding field defects. So when you have corresponding field defects, that is what makes it glaucoma. And there's no question that there is. Now you go on to an OCT, and sure enough, the RNFL defect shows up here. So it doesn't show up on the clock hour or the quadrantic because it's a small defect, it's thin, and it is covered in by everything else, and it makes it appear green, but it's not normal. But if you do a clock hour, it comes up as red, and there is no question at all to this RNFL defect on the thickness map and the fact that it is deviated from normal. So everything corroborates. So what is the problem? So the problem is that you do a GCA and it's completely normal. It's a nice, robust, yellow-orange GCA. There is no deviation from normal, and all the clock hours are completely green. Now what do you think is going on? Now the problem is it's not normal. What has happened is that the ganglion cell loss are outside this 3 millimeter or 5 millimeter circle of the GCC. So it's beyond it. It's somewhere there. If this GCC circle was larger, it would have encompassed those ganglion cells as well, and it would have been shown. So remember, if you have defect at the poles, then the ganglion cells are far away. The ganglion cells that are damaged are far away. So you need a 24-2 or a 30-2 to see that on the visual field, but a 10-degree GCC is not going to pick it up simply because it's not there where it was being imaged, right? Now let's look at a converse thing. There's advanced glaucoma in the right eye. I don't think there's any doubt about that. And the left eye does have an early glaucoma, even though the rim here is not so bad. So you can see that on the field. You can see it's a pretty much advanced superior arcuate scotoma there because it's a large defect and it's a deep, dense defect as well. And the left seems normal. Most of the visual function seems to be preserved. You just have a very small defect here at the center of this disc. You do an RNFL and actually the left eye is normal. So now you're asking yourself that there is a field defect, there are some scotomas, and yet the RNFL in the left eye is normal. There's no question about the right, isn't it? So you tell yourself it's okay, it must be some very, very early defect, which is why it hasn't been picked up, but that's okay, and you reassure the patient you're fine. If you miss it and you don't do a GCC, to your horror, imagine that this ganglion cell analysis shows that the left eye is as potentially blinding as the right. These deep focal defects in the center are pathognomonic of normal tension glaucomas, and those are the glaucomas which are going to go blind. If you don't do a GCA and you don't follow this up on the GCA, you're going to miss it, because here the defect is near the papillomacular bundle. So remember, if they're near the poles, then the GCA remains normal. But if it's nearer the papillomacular bundle here, then the RNFL doesn't pick it up, because the RNFL is a global thing. The ganglion cells are damaged in the center. So when you have a defect which you think is nearer the horizontal, the GCA is going to be important. And the visual fields to do for these patients would be a 10-2. If this was a live class, I would have asked you, kaun sa visual field karna hai? But now I'm telling you, the visual field for this patient's progression is not a 24-2, but it's a 10-2, a 10-degree field with 68 points, so that you can follow up early progression on these patients. Right, so that's why topography is important. Now, having gone through this, what to order? You know, you have so many things. You have the HRT, you have the RNFL, you have the GCA, and then you have a patient in front of you, and you want to do an imaging and want to follow him up for your records. So this is when the OCT is of limited use. So when you have extensive peripapillary atrophy like this, high myopes, most commonly, there's no point doing an OCT. Why? Because the OCT is done in a circle of 3.4 millimeters, and around the disc, the 3.4 millimeters is all taken up by peripapillary atrophy. There will be no segmentation at all, and the OCT is going to show up weird things. So there's no point in even looking at this OCT, because it's of no use. And even for follow-up, remember, OCT is only a machine. So be sensible, use your head. So here, if you see, this seems to be progressing. This is orange and this has become red. And yet when you look at signal strengths, they were only 4 and 5. So remember, for the serous OCT, it is useless unless your signal strength is at least 6. So 4 and 5 signal strength is not imaged, it is not segmented. And so when you go back to your optom and say, isko theek karo, this is not good. You see here, it's come back to 94 and there's no progression at all. So even progression on the OCT is fallacious if you don't know what you're doing. So you can't rely on a machine to do your things for you. Now this is an obvious glaucoma. There's no problem. There's no, it's a small disc. So be very, very careful. But if you see both discs together, look at this nerve optic rim and look at this rim and look at this. This is far darker compared to this. Look at this RNFL. This is white, whereas this RNFL you're not been able to see. 25 and 36 millimeters of mercury, small crowded discs, inferior RNFL defect. No doubt that this patient requires treatment, and there is the RNFL defect there. You have early superior defects on the visual field as well, but look at the OCT. Now what is happening? The OCT is all green. The OCT is all green only because it's a crowded disc. And because it's a crowded disc, all those retinal nerve fiber layers are crowded upon each other. So OCT is only giving you structure, and otherwise it is completely normal on the OCT, but it's not normal. This patient has glaucoma, requires surgery possibly because the pressures are high, but with a small crowded disc, you will mistake your glaucoma and it's reduced, but the machine can't pick up it's reduced simply because it's so crowded together in a small disc that is taken up as green. But if you look at the other eye, which is normal, you see this is white. White means supranormal. It is the highest 5% of normals. So this patient has normally very, very thick. So here RNFLs is actually 150 and 172, whereas the other eye is only 93 and 82. So it's markedly reduced, but statistically, it doesn't fall in the thin category of the normative database, and that's why it is green. So remember that green is not a signal that this patient is normal. You could have glaucoma with the green. Look at this patient, for instance. Now this 64-year-old woman has loss of vision. She has an RAPD, she has normal pressures and a red OCT. A red on RNFL, a red on GCA, and a disc like this. Now, this is a pale disc edema. This is possibly AION, an old AION. Again, in a disc at risk, in a small disc. So you need to be very, very careful with small discs, because a small disc with glaucoma on the OCT is flagged green, and a small disc without glaucoma is flagged as red, because functionally or structurally that tissue has attenuated. So remember that your clinical examination is going to see you through rather than the other way around. So this is some of our publications where we've looked at all kinds of things on the OCT. We've also looked at the OCT pre and post a trab, and actually it was thought that once you do a trab, the retinal nerve fiber layer gets better. It doesn't, because when we followed it up for at least 6 months, that momentary thickness was because of the peripapillary edema after a trab. So that's just one example of ask the right questions and then you'll get the answer. One of the very interesting things was a correlation between the RNFL and central corneal thickness and ocular hypertension, because the question was, why are the thicker corneas in ocular hypertension protected from glaucoma? And we saw that they also had very thick RNFL. So maybe the high pressures, number one, are being recorded high, and number two, even if they are high, they have thicker RNFLs to be protected. So we'll just quickly go on to imaging the angle. Of course, the gold standard is a gonioscopy. It doesn't matter which you use, but in the clinic for everyday purposes, a 4-mirror is a quick way, because you just put in your paracane and quickly you go through both of them. So we use a Sussman or a Bosner or a Vogue, any of them that you use, or a Zeiss for that matter. But it's easier than a coupling agent required for a Goldman. But it doesn't matter if you have a 3-mirror Goldman. The important thing is to do it and look at the angle, and against which a UBM as well as an ASOCT is compared. So all new equipment which comes in is all compared against the gonioscopy. So that really is your gold standard. I love this picture. You can see my hair was much blacker then, so it's from a long time ago, but this 3-year-old girl is allowing me to gonioscope. So saying that a patient is not cooperative is not an answer which is accepted at all. There is no patient who cannot cooperate on gonioscopy. You are the ones who have to give it time and the effort and the patience to be able to do it. So this is the UBM, of course, it needs a cup, and this is the old paradigm. And now the ASOCT has made it better and easier, and it's non-contact. If at all there's a debate on whether to do gonioscopy or use imaging, it might be in screening for primary angle closure disease. But then when we acquired the UBM and we blindedly compared the gonioscopy with the UBM, there was nothing. There was no difference in the ability of the gonioscope to see whether the angle is open or closed. But we found an ability in plateau iris, maybe. But even here you can see this is the sine wave curve. This is the iris, the ciliary body root is pushing the iris up, and therefore it dips in and comes. So if you see this dip on the gonioscope, you know that you're dealing with a plateau iris. But with the UBM, you can see this knuckle of ciliary body much better, which is pushing up the iris. Why is it important? Because those are the angle closures where your laser iridotomy may not work too well, and you might require to do an iridoplasty for it. Right, it's indispensable if you have an iridotrabecular contact present, because you need to ask yourself, is it appositional or synechial? So this is an appositional closure. You just do a little bit of an indentation and you can see the trabecular meshwork opening up. Important to do an LI anyway, but nice to prognosticate that if you can see appositional closure, then doing an LI is probably going to open the angle. Imaging has no answer to this. There is no way that an anterior segment OCT is going to tell you whether this is appositional or synechial closure. You just have to take it that the angle is closed. How would imaging show a Sampaulis's line, or a painted trabecular meshwork in PDS, or a blood in Schlem's canal, or a broad-based PS in uveitis, or even iris processes in Axenfeld? These are just examples of why clinical examination is important. So iris nodules and Cogan-Rees, myovascular glaucoma, emulsified silicone oil after PPVC. These are things which you need to see for yourself. But don't get me wrong. We've worked extensively on the UBM. It's a wonderful, wonderful machine, and it's indispensable when you cannot have a vision of the angle, either because the cornea is not clear, or because you want to see what is happening to the angle behind the iris. So when you can't visualize by light which is what your eye and the ASOCT is going to do, that's when you need ultrasound, isn't it? So you need an ultrasound biomicroscope to image the angle when you can't see it otherwise, but it's not a replacement, they are complementary. So this is again an old picture which I keep showing because it's from our archives of angle recession glaucoma, and this is an angle recession on the UBM, which is an in vivo histology. It shows you the angle as it is. Remember, use of 50 megahertz probes. These are 35 megahertz, no use for doing an angle analysis if you want to. So these are irises, these are topiramate induced angle closures with fluid in the supraciliary region. These are instances which your naked eye examination might not be able to tell you. Again, ciliary body effusion. Sometimes you wonder why post-RAB you have absolute hypotony, so ciliary body effusion could be one. If they're unexplained closed angles, again look behind the iris. Now look at this. Angle closure, large iridectomy done at the time of when surgical iridectomies were done, and yet he comes with angle closure and high pressures. And sure enough, he had a large plateau iris for which he required, as I said, an iridoplasty. You can look inside the trabecular blebs. The question is whether you should revise it or whether you should do a needling. So we've looked at the sclerostomy and the fluid in the sclerostomy and under the scleral vessel, scleral flap with UBM, and we can do a intervention accordingly. This was a very interesting patient. Came with endophthalmitis, persistent endophthalmitis with rosette cataract, so had trauma. Of course, was treated for it. This is the laceration, which was, but the inflammation didn't go away. Received intravitreals, received everything, nothing happened. And then on gonioscopy, we saw this weird looking iris and we thought it had just been caught in the sutures. And here was something very, very suspicious, but the UBM showed this iron foreign body which was embedded in the iris behind it. No other investigation in the world would have taught us this. And you can see the back shadowing. And then this was easy once we knew. We just went in, teased it out from under the iris, and once it was localized, we went in with a magnet, and as you can see, we just pulled out the foreign body from inside, and it was a large iron foreign body there. And you can see post-op, the gonioscopy, it was all clear, and the endophthalmitis finally resolved because of that, because this inflammation wasn't getting better. It's a game changer. Quickly, I'll run through pediatric glaucoma. So it's shown us what is happening to the cornea and what is happening behind, and it's helped us immensely. For instance, when you have a newborn glaucoma, you have no idea what's behind these corneas, isn't it? So it could be just a PCG with a large diffuse corneal edema. It could be, which when you do surgery, it comes back, so it's nice for prognosticating. All white eyes are not always primary congenital glaucoma. It's useful to delineate these Descemet's defects, which is in Peters anomaly. It illustrates beautifully what we know. And I like this because we just did it because we couldn't see behind. And this is actually silicone oil. And this is the silicone oil when the boy lay down. And you can see the silicone oil which is going out and coming back into the angle. So it's a really beautiful thing to do. The anterior segment OCD, I'm not going into details for it, but you must know it's again high frequency ASOCT. The cassia is the one which goes 360 degrees in one go, and that's the one which tells us a lot about the angle. It's a swept source OCT. Angle assessment clinically is good. I like this slide. It's got time, it's laziness, it's easier to send a technician to do it for you. They'll come back, you don't need to do a gonioscopy. So that's possible, but you don't buy a machine for that. There are quantifiable parameters, but what is useful for us is that the pattern of the angle closure can be detected very well. So this angle closure is really telling me that it's a very, very large lens, and possibly just taking out this lens might help. Whereas this, on the other hand, is after this lens is removed. So you can see that sometimes, even with very high pressures, you can just proceed with the cataract extraction before you want to do other things for the angle. Non-pupillary block is important. This is lens subluxation. So you can see the angles are so irregular, and this patient also requires the lens to be out. Sometimes you have a very large lens vault or a cilio-choroidal effusion. Sometimes with the swept source OCT, this is possible without a UBM, but that's rare. It's not so common. You can visualize the blebs. That's very important. This has actually a bleb module. So I'm bringing this in because we're talking about glaucoma and where to image. So now we've largely replaced the UBM with looking at blebs because it shows us the scleral route of the aqueous very well, and we can know whether what we need to do. And then with the glaucoma drainage device, you can see this is indenting the cornea. So if you have a bit of corneal edema there, and you can see this tube which is indenting the cornea, you know that this tube needs to be replaced, because otherwise this cornea is going to decompensate very soon. So it's nice to be able to pick up pathology. The advantages, of course, are it's non-contact, and in situations of anterior segments trauma where you don't want to do UBM too well. But sometimes even with imaging, again, I'm coming back to clinical examination is so important. So this, I think, is the last case possibly. 22-year-old man, decreased vision, acute angle closure, 52 millimeters of mercury. This is something which should set you thinking, why should a 22-year-old man have an acute angle closure? That's very, very unusual. Nothing is impossible in medicine, but this is unusual, and he also had an RAPD and closed angles. So when we looked at the UBM, we saw supraciliary fluid, and then we knew there was something else going on. It's not really just a primary angle closure, it's secondary angle closure disease, but the question is why? And then you look at the fundus and you see there's traction, and you know that there's something going on in the periphery, but he's 22 years old. And then you still have a clinical suspicion of what is the other thing. It can be ROP, but it can be FEVR because he's a normal, familial exudative vitreoretinopathies. You don't really think about them, but when you do the FFA, sure enough, you have peripheral vessels which are leaking, and the leaking peripheral vessels have caused a supraciliary effusion. The supraciliary effusion has closed the angles, and you have acute angle closure. So really, the imaging only told you that there's an effusion, but it set you on, but the diagnosis was made by clinical exam. So to summarize, the approach to any patient always depends on what it is. And what it is evident more often than not by sound clinical judgment. OCT gives a structural assessment in terms of thickness, and imaging the angle and anterior chamber has helped make more informed choices in management. But still, technology is used as an ally rather than a master. Qualitative fundus evaluation will give you many, many clues. Thank you very much. I'd like to acknowledge none of this work can be done on your own. This is our team. We have lots and lots of fun with lots and lots of work. These are my fellows. 3 of them have passed out, wonderful glaucoma surgeons themselves. I'm very proud of being there and very proud of being in this department. Thank you. Thanks a lot.
Thank you, Dr. Sushmita, for so wonderfully taking us through the various diagnostic modalities in glaucoma, and for illustrating it so beautifully with those wonderful pictures and real life examples. So wonderful and very informative talk. So one question that we have.
I think you're muted, I think, Tinku. Yeah.
I'm sorry. Did you hear the earlier part?
Yeah, I heard my tarif. Thank you.
Okay. So one question that we have is, how do you interpret the OCT printout in children where the normative database doesn't have, the data for children, and you don't get the color maps, you don't get the color coded maps in kids?
Yeah,
so are there any pointers to looking?
Yeah, it'll be very rarely that we really use the OCT for children, because it's where for very small children, of course, it's cornea, it's axial length, it's pressure, which is what is more important rather than looking at the OCT. But for older children who come with acquired glaucomas, we just take the baseline and we follow up on that. So we don't look at colors, because there are no colors to look at. Yeah. And it's not a bright idea to put in, so some people also say that you can put in the age as 18 and then look them up. That makes no sense actually, because the colors are only comparing it to a normative database who is 18 years old. Now putting in a 10-year-old child as an 18-year-old and then comparing that normative database to that person makes no sense. So we just look at the values and we follow it up over time if at all we need to. But since you've asked that, I'll just add on a little bit about the visual fields in children. We were very surprised that the visual fields in children appeared to be worse than we thought. So a child where the optic nerve looked all right, why they feel so bad, and repeatedly, and they're cooperative and they understand and all that. We actually did a thesis on that, and actually till about 12 years of age, we compared it to adults of a similar RNFL. So we did the OCTs in them. We matched each OCT of a child to an adult OCT of the same RNFL thickness, and the visual fields were all lesser. And then when we actually looked at literature and looked at the development, the child's functional development is not there till 12 years of age. So it's not that he's not seeing it, it's just not functionally robust. And children more than 12 years have the same visual fields as those of adults. So you can do a 12-year-old child compared to an adult, it's fine, 12 to 18. But less than 12, again, you need to, if you're doing visual fields, you have to look at the raw data of that child and follow the child up with that visual field. So similar to the OCT, you have to follow the child up with the OCT.
Thank you. So another question that I would like to ask you is that in the workup of a suspected glaucoma patient, is OCT an imperative diagnostic tool? Does it have to be done in every case that you suspect glaucoma?
I think so. I think so. In suspects, it's because the OCT would give you the maximum information in early glaucomas. A question that I'm always asked is, would you treat if an OCT shows up something and the fields are normal?
Yes.
So the answer to that would be, I would treat if there's change. So if you're going to ask me that if the OCT is flagged red and the fields are normal, would you treat? No, because it might be that this person is that 1% of normal in that normative database whose RNFL is normal. So even if it is red, there is a 1% in that normative database who is normal but has that thickness. And maybe my patient is that. Remember, the normative database on the OCT is 324 Caucasian eyes, and that's it. That's it. Compare it to the millions and millions of people who are undergoing OCT every day. 1% of that 324 is 3 or 3.2. 3 people out of 300 have an RNFL thickness which would fall into that red. So if you're going to see 3,000 people, 30 would have that and they would be normal. Treating them is not. What my problem would be, change. I would call them back 6 months later. And if there is change, now it should not be progressive if you're normal. So I would treat change. So the answer for me would always be, I'm still a little more conservative. Even if I see change, I would tell that person, look, I'm seeing change, but your fields are still normal. You have no functional problem, and we are assuming because you're saying this suspect that the pressures are normal. So I would tell him your pressures are normal, your fields are normal, but your OCT is changing, and I don't like it. So I am going to follow up other things. Get an MRI, get a neurological consult. Are you on steroids? Are you on creams? Is it a fluctuation? Do a diurnal variation. Do you have 2 liters of water in the morning? Do you have a spike in the morning which is causing a change and I'm not seeing? So look at other things then, so your index of investigation increases, but treatment at a drop of a hat is something which, and I remember when I was very, very early and just getting into glaucoma, I heard Dr. Harsh's. I used to hang on to people, all lectures, everything I could. And one thing which has stuck, and I want to reiterate Dr. Harsh's statement, if you do glaucoma seriously, you will spend far more time taking people off medication than putting them on. It is so true. It is so true. If you don't see it. That's one message I want.
Yeah, very nicely reiterated. One more thing is that how often would you advise a visual field to a patient who's already, a glaucoma patient on treatment? How often should the visual field be repeated?
Depending completely on the stage of glaucoma. So early glaucomas, this suspects, okay, let's put it, OHT this suspects, not more than annual, maybe even annually to start with. If they remain normal, maybe go on to 18 months. Moderate glaucomas, 8 to 9 months. Severe glaucomas, 3 times a year. So 3 times a year, twice a year, once a year, once in 1.5 years, depending on the stage, because it's not middle. But the advanced glaucomas, one-eyed, 3 months. So then even if I don't have an appointment, I have to write to my optom, please, iska kar do, because I need it.
So this is a patient with well-controlled IOP,
Yeah.
a patient who's on glaucoma medication, advanced glaucoma with a well-controlled IOP, still 3 times
Three times a year at least, because
Okay.
and on 10-2, because you never know with these people, with their fluctuation, when they are going to tip. And when they tip, it's really, so visual field is the only thing we have. We don't do OCTs in advanced glaucomas at all. Not at all. So OCTs are only done in the early ones. And if the OCTs are absolutely the same, maybe we don't even do the visual field. We'll defer the visual field to 2 years. So we'll say you don't need a field now, it's fine. So that's the other thing. But it depends on the stage of glaucoma completely.
Okay. And what is the protocol? There's another question. What is the protocol that you would follow at the first visual field testing that we're doing? Is it just 30-2, or would you like to do a 10-2 or 24-2?
No, 24-2 SITA standard is the usual. 30-2 because it takes more time, but 24-2 gives you equivalent information. But they need to learn to do the visual field, so I want a threshold. So SITA standard threshold 24-2 is the first until they learn. Then I switch on to 24-2C. 24-2C is a wonderful program because it has 10 additional points in the center, which are 2 degrees apart. So it's called 24-2C. But the problem is it is supra threshold. So it is assuming that the patient knows what is a target and can press. So therefore, once the learning curve is done and I have reliable visual fields, they go to 24. 24-2C is a 5-minute procedure. It's very fast, but very, very useful for that. And for the normal tension glaucoma that I showed, of course, if you have central deep defects with GCC problems, 10-2. Then I don't go to 24-2. Again, topography.
So you don't.
Topography would direct that, yeah.
So you don't order a 30-2 at all. You just do the 24.
No, we don't order 30-2 at all. No, we stick to 24-2.
And no SITA fast. You do.
So this is faster. This 24-2C is SITA faster. It is supra threshold. SITA fast because if it's not giving 10 degrees in the center, it's no meaning. I might as well do a 24-2C, right? So we don't do SITA fast. We do 24-2 SITA standard. Once they learn the fields, 24-2C. So all the newer machines have a 24-2C, but then if you don't have I think the 750 series has started. But if it's a 720 series, it won't have a 24-2C. There a SITA fast is fine. Once the 24-2 SITA standard is done and the patient knows, because remember the danger of doing just a SITA fast is there's no thresholding. It's only a supra threshold. It's yes and no. If the patient doesn't know what a visual field is like, you'll get a lot of erroneous stuff, and unnecessarily, ultimately, you'll be saying repeat fields. So let them learn before you get into that.
So in the older machines which don't have 24-2C, so then we do a 24-2 and a 10-2 and a 10-2 also.
See,
because we want to
so it's interesting that if you have central defects and they've learned to do the field, it's a good idea to follow them up on just 10-2. But as a baseline, it's a good idea to do one 10-2 because remember, especially in those cases where so when the OCT is red or suspicious and your fields are normal, then I would do a 10-2 as well. Because with the 6 degree separation, you might miss early defects. Now, if I have a defect on 10-2, I would not call it pre-perimetric glaucoma, though the definition is pre-perimetric glaucoma on a 24-2 field. So it's not that. So now everything is changing as we understand. So you might have 10-2 defects with a Garbad OCT and a normal 24-2, and then I would treat. Because 10-2 showed it. That's the one. Achha, that's the one thing about the normal IOP that you're saying. I just want to relate a quick 5-second story that at COVID, we had triage, niche, which the senior residents would do. And they were allowed to come in if they had a problem, but they were screened and there was a density, and if everything was normal, they were told it's okay, and otherwise they would send up. And there's one person, and my senior resident was down, and he's like taking out his drugs and says, "Bata do ye kaise dalna hai?" So he says, "Jao upar, dikha them." It was very advanced glaucoma. "Jao madam ko, you go show her. She'll tell you." No, no, no. She's going to ask. The message is, if your pressures are controlled, it might mean because he's putting it since the last 2 days and
Right.
your fields are progressing. So I have to do that 3 times, 4 times, and then I tell them, listen, since when are you not putting medication? I don't ask them, are you? I know you are not, because your fields are progressing. You cannot have 10 pressures with a progressing field. You are not putting medication, but you will go blind, na? Yes, yes, madam, I have put it only since the last 3 days जब आपके पास आना था. So not only when आपके पास आना था, at the door, they bought it from the pharmacist. They went to the senior and said, जल्दी से tell me how is it, because she's going to ask, कैसे डाल रहे हो? I asked them to take out all the medication, show me. No, no, whatever you've written, no, I'm not interested. You tell me what you're putting. So glaucoma becomes very, very person-centric, because there's so many things going on. So normal pressures, advanced glaucoma, progressing field, be very, very careful with what they do.
Okay. So thank you. We'll take up a few more questions in the end if we have time.
Sure.
And with that, we move on to our next speaker. So our next speaker is Dr. Archana Vare. She's a professor and head at the Department of Ophthalmology at the Government Medical College, Aurangabad. A graduate from the BJ Medical College, Pune, she went on to do a cataract fellowship at Arvind Eye Hospital, Madurai, and the LV Prasad Eye Hospital, Bhubaneswar. With a keen interest in anterior segment glaucoma and neuro-ophthalmology, she has been an undergraduate and postgraduate teacher for the last 21 years and has also published extensively. She is a member of the Task Force Ophthalmology at the Maharashtra University of Health Sciences, Nasik, and a member of the Medical Educational Unit at the Government Medical College, Aurangabad. Today, she will be taking the glaucoma thread forward, and she'll be speaking to us on optic nerve head changes in glaucoma. So welcome, Dr. Archana, and over to you for your talk.
Thank you, Dr. Tinku, for that wonderful introduction. And at the outset, I would like to thank, just again share. At the outset, I would like to thank the All India Ophthalmological Society, Dr. Haribansh Lal sir and Dr. Santosh Honavar sir for giving me this opportunity. Am I audible and visible?
Yes, you are.
Okay.
Please go ahead.
Today, I will be speaking about the optic disc changes in glaucoma. There are no financial interests. So this would be a journey from a normal optic nerve head, and we will discuss how the glaucomatous cupping looks like. So this would be the layout of my presentation, and I would be speaking about the introduction, anatomy, and blood supply of the optic nerve, introduction to concept called glaucoma and its pathophysiology, and the optic disc changes in glaucoma. So glaucoma is a chronic progressive optic neuropathy described by the morphological changes in the intrapapillary and parapapillary regions of the optic nerve head and the retinal nerve fiber layer. And appropriate techniques of clinical evaluation can help differentiate between glaucomatous, non-glaucomatous, and normal optic discs. So now let us see how to examine the optic nerve head. The direct ophthalmoscope lacks stereopsis and indirect ophthalmoscope lacks magnification. But still, the indirect ophthalmoscope can be used for children, for uncooperative adults, and in cases of media opacities. But the gold standard to examine the optic nerve head is slit lamp biomicroscopy. So this is how the slit lamp biomicroscopy is done. And with the graphical function of the slit lamp, we can measure the optic nerve head. So when we measure the optic nerve head, we get a vertical slit like this. Then with the graphical function, the readings, they come over here. And by adjusting this, we can reduce the slit beam in the vertical and the horizontal meridians. And we can have the vertical and the horizontal diameter of the optic nerve head. And a very important clinical tip is always you should take the internal lip of the Elschnick's scleral ring to measure the optic disc size. Then with the help of slit lamp biomicroscopy and with the various lenses and with the corresponding correction factors, we can measure the optic disc size. And the angle between the magnification and illumination should be kept at 0 or less than 10 degrees to ensure stereopsis. The Verishirin direct ophthalmoscope with 5 degrees spotlight can also be used to examine the optic nerve head. And it is very important to draw and photograph the optic nerve. This is particularly important for documentation and also to know the progress of the disease. Now coming to the anatomy of the optic nerve. So we all know that it is the second cranial nerve and it carries impulses from the eye towards the brain. The optic nerve is around 50 millimeters in length, and it has 4 parts as the intraocular, intraorbital, intracranialicular, and the intracranial part. But today we'll just discuss this 1 millimeter length or the intraocular part of the optic nerve, which is also called as the optic disc or the optic nerve head or the papilla. And the macula is situated 2 disc diameters temporal to the optic disc. So let us understand the microanatomy of the retina. Now this is the ganglion cell of the retina, and this is the axon of the ganglion cell. Now this ganglion cell forms a very important layer out of 10 layers of the retina. This ganglion cell, it takes a 90-degree turn and it reaches the optic nerve head. And while doing so, it traverses to the retina, the choroid, and the sclera. There are around 1.2 million retinal ganglion cell axons which converge onto the optic disc. So these retinal ganglion cells, they converge onto the optic disc from all over the fundus and they form the optic nerve. Now coming to the topographic anatomy of the optic nerve head. So the area of the optic disc is around 2.5 millimeters square, the diameter being 1.5 millimeters. The vertical diameter of the optic disc is 1.8 millimeters and the horizontal diameter of the optic disc is 1.7 millimeter. Since the vertical diameter of the optic disc is greater than the horizontal diameter, the optic disc is said to be vertically oval. Now let us discuss something more about the size of the optic disc. So this is a small size disc when the disc is said to be a small sized when its size is less than 1.5 millimeters. It is a medium sized disc when the disc size is in between 1.5 to 2.5 millimeters. And the disc size is said to be large when the disc size is more than 2.5 millimeters. But size by itself does not determine glaucoma. Small discs usually have small cups and large discs usually have large cups. And glaucoma is often overdiagnosed in large discs and it is missed in small discs. For example, okay, now this is a small disc with no cup, and this is an average size disc with an average cup, and this is a large disc with a large cup. Now this is a large disc but a non-glaucomatous cup because there are no other signs of glaucoma present here. But if we concentrate on this disc now, this is a small disc, but we can see the glaucomatous changes and the peripapillary atrophy. So this is a small disc with a glaucomatous cup. Now let us discuss something more about the optic disc shape. We've seen that the optic disc is vertically oval. But we can have a torted disc when the vertical axis of the optic disc is rotated for more than 15 degrees from the vertical meridian, or we can have tilted discs when there is 3D angulation of the anterior-posterior optic cup axis, or we can have bean-shaped discs, or we can have myopic discs. Now, why it is important to know the shape of the optic discs? This is first thing is for documentation, and second thing is these discs with altered shapes, they do not follow the normal ISNT rule, which we'll be discussing later. And that's why it is very important to document the shape of the optic discs. Now coming to the optic cup, it is the central excavation in the optic nerve head. It is devoid of axons and capillaries. The cup depth usually depends on the cup size, and it is usually horizontal in orientation. While we examine the cup, then we should not look at the pallor of the cup, but we should see the change in the direction of the blood vessels as they ride over the cup. Coming to the color of the optic disc and cup, the optic disc is usually orangish pink in color, and the optic cup is pale due to visibility of the collagenous lamina cribrosa. Now, cup to disc ratio. This is the ratio of the vertical diameter of the cup to the vertical diameter of the optic disc, and the vertical diameter of the cup is measured in the same fashion as we measured the vertical diameter of the optic disc. So usual cup to disc ratio or the CD ratio is 0.1 to 0.4. 5% normal eyes have CD ratios larger than 0.6, and that is physiological cupping. Some individuals have no visible cup. Now, symmetrical optic cups. It is very important to have a bilaterally symmetrical cup to disc area. As our feet and our hands are bilaterally symmetrical, it is important to have bilaterally symmetrical cup to disc ratio. Asymmetry of the cup to disc ratio is suggestive of glaucomatous change, and more than 0.2 CDR difference should raise a suspicion of glaucoma. Now, coming to the neuroretinal rim. This is the most important and the most critical parameter of the optic disc evaluation in glaucoma. So what do we mean by neuroretinal rim? Now, we've seen that the optic disc is vertically oval and the cup is horizontally oval. So the neuroretinal rim is the distance between the cup margin and the optic disc margin. And so this red thing is the neuroretinal rim. And on an average, the inferior rim is 18% thicker than the superior rim. And that's why there is something called as the ISNT rule or the isn't rule. So the ISNT rule states that there is maximum density of the nerve fibers, which is seen in the inferior quadrant, followed by the superior quadrant, followed by the nasal quadrant, and the lowest density of the nerve fibers is present in the temporal quadrant. So this ISNT rule states that the maximum concentration of nerve fibers is present at the superior and the inferior poles. Now let us discuss briefly about the divisions of the optic nerve head. So we have 4 divisions of the optic nerve head as the surface layer, prelaminar layer, laminar layer, and the retrolaminar layer. So this is the surface layer, which is in continuation with the internal limiting membrane of the retina. Then we have the prelaminar layer, which is present in the choroid, and it is the anterior part of the lamina cribrosa. So this is the laminar layer or the lamina cribrosa, which is the most important part, and it is present in the sclera. So it is a sieve-like structure. It has fenestrations through which the bundles of the axons of the optic nerve they pass through. And the bundles of the axons, they are held together with the help of glial tissue like this. And then we have the retrolaminar layer, which is the posterior part of the lamina cribrosa. Now, this is a very important slide which tells us about the supportive structures of the optic nerve head. So this is the internal limiting membrane of the Elschnig, which is in continuation with the internal limiting membrane of the retina. And we can see a central deepening of the central meniscus, which is the central meniscus of Kundt. And then we have the intermediary tissue of Kundt and border tissue of Jacobi and Elschnig. Now, what is the clinical importance of this? Now, we know that in glaucoma, there is regeneration of the neurons, but only these supportive structures, they remain behind after the regeneration of the neurons. So if we take a cross section through the lamina cribrosa, then we see something like this. Now, these are the vessels in the optic nerve, and this is the superior pole and the inferior pole. If we see the pore size in all the 4 quadrants, then we can see that the pores are larger in size at the superior and the inferior poles. And as the pore size is larger, there is less glial tissue, and the larger pores and less glial tissue makes it more prone for damage. So the lamina cribrosa is the main site of glaucomatous damage. Now let us discuss briefly about the distribution of the retinal nerve fibers in the optic nerve. So this is the optic nerve and this is the macula. The fibers from the macula to the disc, they pass in a straight fashion as the papillomacular bundle. And the fibers from the superior and the inferior temporal area, they always respect the horizontal raphe. They arch over the macula and then they reach the optic disc. And the fibers from the nasal, superior and inferior nasal quadrants, they are called as the arcuate fibers. They go in radiating fashion towards the optic nerve. Now, let us see the distribution of the retinal nerve fibers in the optic nerve. So this is one retinal nerve fiber, which is marked with a star, and this is the another one which is marked with a diamond. Now, this retinal nerve fiber, it is present at the peripheral part of the retina, and it assumes the peripheral portion in the optic nerve head. And this retinal cell or the ganglion cell axon is present nearer to the optic disc, and it assumes the central position in the optic nerve head. So what is the clinical relevance of knowing all this? The arcuate fibers are more sensitive, the macular fibers are most resistant. So the localized optic disc damage can lead to corresponding visual field changes. For example, now here if we see, this is the optic disc, and we can see inferotemporal RNFL defect, and this corresponds to the corresponding superinasal visual field defect. Now let us see the blood supply of the optic nerve. The optic nerve receives its blood supply from the retinal circulation and ciliary circulation through the central retinal artery and the short posterior ciliary arteries respectively. So this is the ophthalmic artery, and the central retinal artery is the first branch of the ophthalmic artery. So this central retinal artery, it supplies blood to the optic nerve. Then these short posterior ciliary arteries, they form the circle of Zinn and Haller in the sclera, and they also supply the optic nerve head and the optic nerve, and the peripapillary choroidal arteries and the pial vasculature, they also contribute in the blood supply of the optic nerve. One more important thing here is the blood is drained by the central retinal vein, which drains into the superior ophthalmic vein. Now coming to the pathophysiology of glaucoma. So now let us build a concept called glaucoma. Now there are two theories, the mechanical theory and vascular theory. And the intraocular pressure may or may not be raised, but the optic nerve is damaged, and there are corresponding visual field defects. So what are the theories behind the glaucomatous damage? So the pressure theory states that there is direct damage by the pressure, and the ischemic theory states that because of the capillary occlusion, there is glaucomatous damage. So both these lead to the interference with the exoplasmic flow. So the normal or the high intraocular pressure leads to mechanical damage. Decrease in the optic nerve head perfusion leads to ischemia. Both of these, they lead to decrease in the exoplasmic flow and the stasis of the exoplasm, and leads to programmed ganglion cell death, that is called as apoptosis. So these are the changes which occur in the lamina cribrosa. So there's posterior bowing, and there is mechanical thinning in the lamina cribrosa. So with this, let us define glaucoma. So it is a chronic and progressive irreversible optic neuropathy with typical optic nerve head changes and corresponding visual field changes. The pressure may or may not be elevated, and rise in the intraocular pressure is the only modifiable risk factor. Now let us begin the optic nerve head changes in glaucoma. So they are divided as papillary changes, vascular changes, and peripapillary changes. So first we'll discuss the papillary changes. So these papillary changes are large cup to disc ratio, vertical cupping, progressive optic nerve cupping, asymmetric cupping, disc hemorrhages, and laminar dot sign. So let's first discuss about the large cup to disc ratio. So it is the most common but the least specific change. Some large optic discs can have large cups and still normal rim tissue, and cup to disc ratios over 0.6 should raise suspicion, and it is always a good practice to get the baseline photographs. For example, here we can see the large cup to disc ratio in non-glaucomatous eyes. And here also we can see the large cups in glaucoma, and these are suggestive of the optic disc changes which occur in glaucoma. Then here also we can see a large cup to disc ratio, and here we can see there is a loss of the neuroretinal rim here. Then this is large cup to disc ratio. We can see the cup to disc ratio is almost 1 here in advanced glaucoma, and we can also see the other signs as bayoneting, which we'll be discussing later. So why there is increase in the cup to disc ratio? This is because of the changes in the NRR contour. So there is thinning of the neuroretinal rim, which may be a diffuse thinning or it may be a focal thinning. And the focal thinning is most commonly seen in the inferotemporal quadrant. So this is the diffuse thinning of the neuroretinal rim. Then now look at these two discs. Both these discs show the CD ratio of 0.5. But here the contour of the neuroretinal rim is well maintained. But here if we see, then there is inferotemporal loss of the neuroretinal rim here. And it is suggestive of the focal notching. So the contour of the NRR must be observed carefully. Now here we can also see the bipolar notching at the superior and the inferior poles. And here we can see there is focal notching at the inferior pole. So here also we can see the focal notching at the inferior pole. Now the next change is the vertical cupping. A vertically oriented cup is more concerning than a horizontally oriented cup, and focal changes are more characteristic of damage. So we have seen that normally the optic disc is vertically oval and the cup is horizontally oval, but in glaucoma, the cup also becomes vertically oval. So this is how the vertical elongation of the optic cup looks like. And here are examples of the vertical cupping. Here we can see that there is increase in the vertical cup to disc ratio. And here it has almost become 0.7 to 0.8. And here also we can see the vertical cupping. Now the next change is the progressive optic nerve cupping. Documented progressive cupping is by definition glaucoma. In glaucoma, the pink rim becomes thinner and this results in a large cup. Now, for example here, the patient first, we had seen the patient and the CD ratio is 0.3 here. Then there is vertical elongation of the optic cup, but still here, the contour of the neuroretinal rim is well maintained. Here, the cup to disc ratio has become 0.7 and there is loss of the neuronal tissue at the inferotemporal quadrant. And here there is loss of neuronal tissue at the superior and the inferior poles, and the CD ratio is almost 0.9. And here there is complete atrophy and the CD ratio has almost become 1. So what is the effect of this on the visual fields? Here the visual fields are normal. Here also there is no loss. But here, as there is a loss of the inferior field, there is superior field is lost here. And here also we can see the superior and inferior loss, and here the patient becomes blind. So this is how the progressive cupping it takes place. And here, now if we compare these two pictures, then this patient first it was seen in 2000 and then 2022. So over a period of 22 years, we can see that there is increase in the cup to disc ratio. And so there is progressive cupping. And if we see carefully, then there is a presence of a splinter hemorrhage on this disc. And then here also, over a period of 21 years, we can see that there is progressive cupping and the other signs of glaucoma like bayoneting and the peripapillary atrophy, they are also seen. So here is one patient and who has been seen in 2006. Here we can see that there is increase in the cup to disc ratio. Here there is further increase and the other signs of glaucoma, they are also present here. And here we can see the cup to disc ratio has almost become 0.9. And we can see there is nasal shifting and the other changes of glaucoma. So when the cup to disc ratio is 1 and there is complete loss of the neuroretinal rim, then it is called as the bin pot cupping or the cavernous optic atrophy. So this is the normal optic disc. Then this is progressive increase in the size of the optic disc, and this is the bean pot cupping. So the bean pot, this is the bean pot. So the optic disc looks like this, and hence it is called as bean pot cupping. So here we can see the advanced glaucoma with the bean pot cupping, and here we can see the changes that are occurring in the lamina cribrosa. There is thinning of the lamina cribrosa and posterior bowing of the lamina cribrosa. So the next change is the asymmetric cupping. We have discussed that whenever there is a CD ratio difference of more than 0.2, then it should raise a suspicion of glaucoma. So in these two pictures, we can see there is asymmetric cupping. Here the cup to disc ratio is 0.7 to 0.8, and here it is 0.4 to 0.5. Then this picture also shows asymmetric cupping. And here if we see this cup to disc ratio is 0.6, 0.7, and here it is 0.3. And here we can also see a splinter hemorrhage. So now in this picture, this patient had trauma to the left eye, and we can see advanced changes of glaucoma in the left eye. So we must, whenever we see asymmetric cupping, then we must rule out the trauma or angle recession glaucoma or pseudo-exfoliation, etc. So this picture also shows asymmetric cupping. The right eye is almost 0.9 to 1, and the left eye shows 0.5, 0.6 cupping. So the next change is disc hemorrhages. Disc hemorrhages are named after Professor Stephen Drance, who was a Canadian ophthalmologist and who has served in the field of glaucoma for more than 60 years. So he was the one to discover these disc hemorrhages for the first time. They're the splinter hemorrhages, and they're especially seen in normal tension glaucoma and diabetes. And in ocular hypertension study, they have proven that the disc hemorrhages are a major risk factor for development of primary open-angle glaucoma. They're a sign of active disease. They resolve with time. They're flame-shaped and usually present at the disc margin, and they're commonly seen in the inferior quadrant with focal RNFL defect or a rim notch. So this is how the disc hemorrhage looks like. So the disc hemorrhages are flame-shaped because they are present in the superficial retinal nerve fiber layer. And but when they are present on the surface of the disc, then they are deep hemorrhages. Now this patient did not have a splinter hemorrhage on the initial visit, but when the patient came for a follow-up, then we can see there is a splinter hemorrhage at the inferior temporal disc margin. So this is a sign of an active disease. Then it is rare to see two disc hemorrhages or more than one disc hemorrhage at one time. Then now, if we see this patient had a superficial or flame-shaped hemorrhage at the inferior pole, and after 3 months, the splinter hemorrhage has disappeared, but then it has been replaced by the inferior temporal nerve fiber layer defect. And the last papillary change is the laminar dot sign. The laminar dot sign, again, a non-specific sign, but it signifies visible lamina cribrosa, and it goes with a dip cup, and it can be physiological. Now, this is a laminar dot sign where we can see the circular pores in the lamina cribrosa. And there are three shapes of the laminar dot sign, and they may be circular or oval or striate shaped. Then coming to the vascular changes. So there are 4 changes that we'll be discussing: bearing of the circumlinear vessels, bayoneting of vessels, nasal shifting, and collaterals. So let us begin with bearing of the circumlinear vessels. Now in this diagram, we can see that the CD ratio is 0.3 to 0.4, and the blood vessel will go like this. But whenever there is increase in the cup to disc ratio and there is loss of the neuronal tissue, then the blood vessel loses its support, and it becomes exposed, or it becomes naked, and it is seen as if it is hanging in the air. So these are the clinical examples of the bearing of the circumlinear vessels. Now the next sign is bayoneting or kinking. Now, what do you mean by a bayonet? A bayonet means it means a knife which was used in the rifles in the old times. So this is a knife, and this is the rifle. Now, whenever there is advanced glaucoma, then what happens is there is a deepening of the cup, and the blood vessel has to ride over the margin of the deep cup, and this is called as bayoneting. For example, this is the normal optic disc, and here the blood vessel will go like this. But whenever there is the bean-shaped cupping, or in advanced glaucoma, the blood vessel will go like this. So the blood vessel becomes visible at 2 points. So it is visible over here, and it is visible over here. But it is not visible through the margin of the cup. And this is called as, the blood vessel is seen as if it is diving into the deep cup. So this is how the blood vessels in advanced glaucoma, they rise over the acutely formed cup. And this is the bayoneting sign, how it looks like. So here we can see the double angulation of the blood vessels. And the vessels crossing the rim, they disappear into a deep cup as if they are diving into the deep cup. So this is again example of the bayoneting. So let us discuss something about the nasal shifting of the blood vessels. And here we can see that the CD ratio is 0.3 here. And here in advanced glaucoma, there is increase in the progressive, or there is increase in the cup to disc ratio, and there is nasal shifting of the blood vessels. So the nasal shifting is not specific again, because in large discs, we can see here, this is a large disc with no glaucoma, and there is nasalization. And here we have advanced glaucoma, but no nasalization. But nasal shifting of blood vessels, if it is seen in the progressive phases, then it is important. For example, here the patient did not have the nasal shifting. Here we can see the blood vessels, they are centrally placed. But here over a period of 20 years, we can see that there is a progressive increase in the cup to disc ratio and there is nasalization of blood vessels, then it is significant. Now, let us discuss something about collaterals. So we've discussed that the blood is drained through the superior ophthalmic vein via the central retinal vein. But whenever there is increase in the intraocular pressure, then this venous drainage is disturbed and there is formation of the opticociliary shunts, and they are seen as collaterals on the optic disc margin. So here also we can see a chunk of collaterals on the optic disc surface in glaucoma. Now coming to the last segment of my talk, that is the peripapillary changes. So peripapillary changes are of two types, the RNFL changes and the peripapillary atrophy. Now we've seen that the maximum density of nerve fibers is seen at the superior and the inferior poles. And the healthy RNFL, it obscures the blood vessels. The retinal nerve fiber layer defects are of two types, diffuse and focal. The focal are also called as wedge-shaped defects. So this is an inferior temporal wedge-shaped defect, and these are best seen with a red-free light. So this is how the fundus is seen with the red-free light. And here we see there is a focal wedge-shaped defect here, and it is better picked up on the red-free light. And here we can see this RNFL defects at the superior and the inferior poles. The notch and the RNFL defect, they coexist many times. So this is the RNFL defect and this is the inferior notch. And it is also very common to see a notch, the splinter hemorrhage and the RNFL defect. So here also we can see the splinter hemorrhage with RNFL defect. And now in this picture, when the patient came for the first time, the patient did not have the splinter hemorrhage. But here if we see on the follow-up, the patient has developed a splinter hemorrhage with corresponding RNFL defect. Now, coming to the last peripapillary changes. So there are two types of changes as a seen, beta zone and alpha zone. The beta zone lies next to the optic disc and the alpha zone lies peripheral, towards the periphery of the beta zone. And this is how the beta and the alpha zone look like. Zone beta is seen because the RPE or the retinal pigment epithelium does not reach the optic nerve head and it is usually white in color. And the alpha zone is suggestive of dark areas of thickened RPE and they're usually gray or black in color. So this is how the peripapillary atrophy looks like. So this is the zone beta and this is the zone alpha. And a word about the gray crescent. These are the crescent-shaped areas of slate gray pigmentation in the substance of the peripheral optic nerve head. So zone beta and zone alpha, they're not present in the substance of the optic nerve head, but they are towards the periphery. But gray crescents are seen in the substance of the optic nerve head. More common in African American patients and not associated with increased risk of glaucoma. So what is the clinical relevance of this peripapillary choroidal atrophy? They may be normal or abnormal. These are areas of weakness, but if progressive, then they indicate glaucoma. So now this patient on the initial visit did not have peripapillary atrophy, but over a period of 16 years, the patient has developed the peripapillary atrophy. So this is suggestive of glaucoma. Then here also we can see over a period of 20 years, we can see there are other glaucomatous changes and the peripapillary atrophy. These are bilateral peripapillary atrophies. And when this peripapillary atrophy is present all 360-degree around the optic disc, then it is called as haloglaucomatosis. So this is how the haloglaucomatosis looks like. So now let us summarize. We'll summarize the signs of the progressive optic nerve damage, and they are changes in the NRR contour, development of a notch, shift in the position of the blood vessels, disc hemorrhages, especially recurrent, progressive changes in the retinal nerve fiber layer, enlargement of the peripapillary atrophy, especially the beta zone, and development of a focal NRR pallor. So the take-home message is the changes in the optic nerve usually precede the visual field loss. A significant amount of nerve fiber damage occurs before the visual field loss manifests. So optic nerve head examination is very important in the care of glaucoma patients or glaucoma suspects. And thank you very much for your patient hearing.
Thank you, Dr. Archana, for that wonderful talk. You very nicely explained all the finer points of doing a disc examination and everything that we should watch out for. A few questions that we have. Could you just give us a few tips on what are the methods of examining the optic nerve head? Should it be done, with a direct ophthalmoscope, a 90D, or a photograph? What would you recommend?
Okay, so the direct ophthalmoscope, it lacks stereopsis, but it is a very handy tool. So when we want to screen the glaucoma patients, then we can do the direct ophthalmoscopy. And indirect ophthalmoscope, it lacks magnification, but still it can be used for uncooperative adults or in cases of children. But the gold standard is to use the slit lamp biomicroscopy. Then photography of the optic nerve is very important because there are subtle changes, like we can miss out on the splinter hemorrhages on the clinical examination, but we can pick them up on the optic disc photography. So each tool has its own merits. So according to the patient, we should choose the appropriate tool for examination and for documentation of the optic nerve head.
And for the disc photography, would you just suggest a color photograph or also a black and white red-free photograph also?
See, the red-free photographs are more useful for the peripheral, the nerve fiber layer, but we should advise the color photograph of the optic disc for the optic nerve head.
Okay. Thank you so much. Dr. Sushmita, any comments on this? Anything that you'd like to add?
Looking at the optic disc is the most important thing, I think. I mean, if you, at least, even if you have a direct ophthalmoscope, at least look at it. But otherwise, the general practice, because everybody's on the slit lamp, is a 90D lens, which is quicker. You don't have to get up from anything. For both the indirect and the direct, you would have to leave that. So I think for convenience, a 90D or a 78D on the slit lamp is the easiest. And you can also see through a small pupil, so that's what we do usually.
Dr. Archana, any tips for evaluating the optic disc in high myopes? In these myopes may have a tilted disc or they would have peripapillary atrophy. So some tips on that where you would be able to diagnose.
Evaluation of a myopic disc is a struggle, or it is a challenge because they do not follow the normal ISNT rule or the normal parameters which are seen in the normal optic discs. So it is a challenge, but then you have to for documentation, you have to take the photographs of these myopic optic discs, and we should always see the progress, like how they are progressing. So on the follow-up of the patients, we should again take the photographs and see there are the other glaucomatous changes that they are seen. Apart from the optic disc, we can see the changes in the retina, and those can also be picked up. So follow-up and documentation is extremely important.
Okay. Thank you. So you've well driven home the point that documentation is an extremely important part of any glaucoma workup, and a very close follow-up of these patients as and when required, with proper investigative tools at every step. So I thank all the speakers for their very wonderful talks. You've very nicely discussed the finer points and intricacies of the subjects that you spoke on. And I also thank the audience. Dr. Santosh, would you like to conclude?
I think it was a very nice series of lectures today. 5 of them, they all spoke very well, covered everything, I suppose, the topics that they had chosen themselves. We'll come to you next week again with the 4th edition of GuruSangam. Please look forward to it.
Thank you. Thank you, sir.
Thank you, everyone.
Thank you for your wonderful moderation as always.
Thank you, sir. Thank the audience who joined in and were very active. Look forward to their presence again next week. Thank you, everyone.